Before we jump into the content, just a couple housekeeping things, couple reminders for you. Those online learnings you need to do for FEMA and the state of Vermont, so NIMS 100, NIMS 700, hazmat awareness, and the mandatory reporting, those are all going to be due on Monday after our in-person session on the 24th, so they're going to be due on the 26th. Also, just a reminder, if you missed any of the live lectures, I will not count you present unless you watch the recording and answer the exit ticket on the way out. So if you've communicated with me about missing any lectures, you need to do those before the 26th as well. If you don't make them up, I can't consider you passing the course. All of these hours are required to pass. It is a short class, so if you don't make those up before the 26th, we won't be able to complete you. So make sure you do those, all right? That being said, we're going to jump into what we have. Good news for you, we're going to go until we're out of topics, so who knows how long this will last. We do have some important things to talk about tonight, especially some things that are going to translate directly into the certifications you need that we're going to give you on Saturday. So things like CPR and stop the bleed. So you're going to want to pay attention to these. And the other topic that we have tonight is traumatic injuries. So talking about potential broken bones, burns, backboarding, using C-collars, doing spinal assessments, all sorts of fun stuff. Now that being said, because we are talking about trauma, I do have another disclaimer for you. We are using some images and videos of real traumatic injuries, and I'm not doing this to scare you, I'm not doing this to gross you out, I'm doing this to show you what injuries look like so that you'll know and be prepared on scene. These are only for educational purposes. Now we're going to start with the big stuff. I wanted to get this out of the way. I wanted to prime you right off the bat with cardiac arrest. All right. This is a big part and a big emphasis on the VEFR certification in general. We're going to talk about why, but this is a skill that every medical provider really needs to know down pat, and you're going to have to know everything in and out about CPR. Good news for you, it's pretty straightforward, and I like to talk about it, so no big deal. Pop quiz for you, multiple choice, don't freak out. My question is, what is a cardiac arrest? All right, is it A, the heart stops beating completely? Is it B, the heart commits a crime and gets arrested? Is it C, the heart does not pump enough to support life? What do you think? C, I get you. I see you, Mark. Good. Yeah, it's C. You know, technically it can be A as well, but if we're looking at the generalization of all cardiac arrests, it's going to be C. In fact, we hope that it's C and not that it's A, because a heart that's not beating at all is harder to bring back than a heart that is just not beating well enough. Okay? And if we're going off of just basic generalization of English, B is also correct. Now, my next question for you is, if somebody's in cardiac arrest and we need to do CPR, so we're going to be pressing on their chest, we're going to be compressing their internal organs, what do we become? What is our goal? Are we trying to wake them up by providing stimulus? What are we doing? What do we become? Yeah, exactly, Brian. The heart. We become their heart. And I think that's really nice. Somebody's dead. Their heart's not doing any work, right? It will stay that way unless we do something about it. Our heart is beating. It's letting us move this meat sack around, right? And we can push on somebody's chest and circulate their blood for them. That's amazing, right? We become their heart. So when we push down on their chest, we're circulating their blood. And when we lift off their chest, we're letting their heart refill. So that is just as important, recognizing that we're not trying to wake them up. We're trying to circulate their blood. Now, what I have here is essentially a rough timeline of every single cardiac arrest call that I've been on. All right, I've done dozens of cardiac arrest calls. The oldest person I've done CPR on was probably around 100, and the youngest person I've done CPR on was around 2 months old. Okay, so I've done this plenty of times. Now, what I've created is kind of just a generalization of how long it takes during a cardiac arrest situation for things to happen. So, of course, the first things first, somebody has to go into cardiac arrest. Okay, so what I've kind of estimated here is that somebody goes in cardiac arrest And then 2 to question mark minutes later, somebody will call 911. It's going to take around 2 to question mark minutes for somebody to determine this person's in cardiac arrest and needs help. My example is like, let's say we're in an actual classroom right now and not just over Zoom, or maybe even over Zoom, right? Let's say I just kind of collapse and I don't get back up, right? You're going to spend 2 minutes being like, that's funny, Kevin. He dropped and he's teaching us about CPR. That's really funny. And then you're going to be like, okay, he's not getting back up. I don't think the internet went out. What's going on? I don't know his address. What am I going to do, right? It's probably going to take you about 2 minutes to realize there's an emergency, maybe a little bit longer. But if I'm in my office by myself and I collapse, question mark minutes, right? Who knows? So optimistically, 2 minutes before an ambulance is called. Now, depending on where the ambulance service is, depending on where the ambulance is, it'll take between 5 and 30 minutes for an ambulance to get there, especially in the state of Vermont. There are plenty of places where the standard wait time is 15 minutes, right? Because it takes a long time to get there. There's a lot of rural communities, remote communities, with few ambulance services to the number of people. So even at St. Michael's Rescue, which is in Colchester, we would respond to Heinsberg. They had a first response agency, so they'd have people doing first aid, but it would take us 25 minutes on a good day, even with lights and sirens, to get there. So, optimistically, 5 minutes, right? Responding from Colchester to Winooski, 5 minutes. Very easy. Heinsberg, longer. So then when we get there, right, an ambulance crew, we're going to start our assessment, and we're going to start CPR pretty much immediately. It's going to be very easy for us to tell that somebody needs compressions. Now, Vermont protocols tell me I'm going to do CPR on scene, so at the place that we find that person, for at least 20 to 25 minutes. And the entire time I'm assessing things and determining whether or not I'm actually going to bring them to the hospital or I'm going to stay on scene. Now, after those 25 minutes, we make our transport decision, right? And then we've got another drive to the hospital. Optimistically, 5 minutes. If we're in the Winooski Circle, less than that, like 3. Because we just go right up Colchester Ave. But if we were in Heinsberg, maybe even further away, right? 30 minutes. There are some ambulances who need to drive like an hour to get to Burlington, right? Remember I told you about like level 1 trauma centers? They're trying to bring somebody super sick to a local hospital that can't manage them. Now they're going to have to drive an hour. So this could differ, but the entire time they're getting CPR. Now, this is where our rules stop, right? We arrive at the hospital, we transfer care, we give it over to the doctors and to the surgeons who are going to be able to hopefully keep them alive. Now, my next question to you is, how many minutes can the brain survive without blood flow, without oxygen? That's exactly what you asked, Eva. So I see 5 minutes, 5 to 8, 3 minutes. It's actually about 6 minutes. So the brain will stay relatively preserved for about 6 minutes, and then at that mark, that's when it's going to start to die. It doesn't just shut off at 6 minutes, but every second, every minute after that, this person's chance of survival and survival where they don't have any neurological deficits declines really rapidly. Now, based off of this chart, optimistically, how many minutes will it take for an ambulance to arrive and start CPR? Seven minutes, right? Best possible case, 2 minutes before 911 is called. Best possible case, 5 minutes before an ambulance arrives. That's still too long. That is 7 minutes, right? It's unfortunate. And that's why you guys are now VEFRs, or you're going to be, right? This is why this idea has come around, because it's not enough for an ambulance to show up. CPR has to be started before that. So having people like you in a community who are trained and understand how to do CPR and know who to call, that's what saves lives. It is immediately recognizing somebody needs compressions, beginning those compressions, and calling for extra help. Okay, so it only takes 6 minutes before the brain begins to die, and all of our data shows people will have a much higher chance of surviving if CPR begins immediately and an AED is applied as soon as possible. When you're doing chest compressions, this is the most important thing you can do, okay? It might sound rough when I say it like this, but if we're doing CPR on somebody and they're in cardiac arrest, they are dead. You are preserving a corpse, okay? Just doing compressions will not bring them back to life. What will is the combination of compressions and AED. What compressions are doing is we are preserving them. We are circulating their blood. We're making sure their internal organs are still getting some oxygen so that the tissue of their heart is receptive to electrical activity. Dead tissue doesn't receive electricity. Perfused tissue does. So the longer we can circulate their blood, the more compressions we can do for the most consistent amount of time, the higher their blood pressure gets, and the more likely they are to regain a heartbeat after we shock them. So essentially, the heart, like we said, it doesn't stop completely all the time when somebody goes into cardiac arrest. There are actually two very common rhythms or arrhythmias that happen. And what these are doing is it's keeping the heart moving. There's still electricity going through, but there isn't actually any blood being circulated. So the heart is still alive, it's still twitching, but there's no blood being pumped out through it. So even though they've got electrical activity in their heart, you will not feel a pulse. They will not be breathing and they will not be conscious. Okay? See in the chat a question, how long are compressions done before it is decided to stop? So compressions will probably go forever unless a doctor is seen. We try to do continuous compressions in combination with AED use and shocking, but for our protocols, which we're going to talk about later, if we do compressions for 20 minutes on somebody and we don't give them any shocks and we don't see any change, we're going to stop after around 20 to 25 minutes. But if we keep shocking them, if we keep seeing electrical activity in their heart, we're going to transport them, and sometimes people get worked for hours, right? Oftentimes they will be in and out, right? They'll have a heartbeat for a little bit, they'll be very unstable, it'll go out, they'll start CPR again, and most of the time this happens for a while at the hospital. So VFib and VTAC, these are what we're actually hoping to see. If we put an AED on somebody or we looked at their heart rhythm and we saw it flatline, right? I didn't bring in another Grey's Anatomy clip, but I really wanted to, how they always go, he's flatlining, shock him. And then the guy wakes up and he's like, oh, you saved my life. I love you, right? It's not how it works. We do not shock people when they have asystole. It wouldn't work. That's just like punching a dead horse, okay? We only shock people if they still have electrical activity in their heart, because if there's still electricity rattling around in there, a shock to the heart is like a slap in the face saying, get your crap together, start beating normally. And most of the time, or hopefully, it'll work. So we want these to be around. And that's what our AED is trying to pick up. It will not tell you to shock if these two things aren't around. It will only tell you to shock if it picks up one of these two. Now, our assessment of somebody in cardiac arrest is going to be pretty straightforward. They're going to be unresponsive. They will not wake up to verbal or painful stimulus. Their skin will be pale, very pale and gray. It turns from like that kind of pale, sick color to gray. If you've ever seen like a CPR mannequin, they kind of look like that. They do a pretty intense or pretty good job on some of them, making them look gray. We're going to always check their pulse on their neck in the carotid artery. So if any of you, if you find your Adam's apple or your trachea, so like if you talk and it's right there, everyone do it, find it right there. And then you're just going to let your fingers slide right into the little divot next to it. You'll feel a nice strong pulse. Don't push too hard, just hard enough to feel it. Right up in here. That's where we're going to check. Because when somebody is having a severe medical emergency, their blood shunts to their chest. So even if somebody has a heartbeat, say maybe they had a really severe seizure, and they appear unresponsive, you might not feel a pulse at their wrist, but they still have a pulse here. So we always want to check here because this is the closest, biggest arteries to the heart, so it's the strongest pulse we will find. We're only going to do that for less than 10 seconds. If we don't feel a pulse, we don't hear or see any breathing, we're going to just immediately start CPR. Good news is, if you start CPR and they don't need it, they will probably go, ow, and you can stop, right? But if they don't make any noise and you still don't feel a pulse, keep going, all right? Now, another thing about Vermont is we have a different way of doing CPR than some of the other states in the country. We are still going to certify you based off of American Heart Association standards. That's what I am. I'm an American Heart Association CPR instructor, but I'm also going to emphasize to you and train you on how Vermont does it. So we do something called high performance CPR, and it's a new style that came out in like 2014, 2015 with some amazing results. We're going to talk about it a little bit more later. In general, right, American Heart Association and Red Cross right now, their guidelines are to do 30 compressions for every 2 ventilations. So pretty standard, right? You do 30 compressions, you take a 2-second break, somebody pocket masks or BVMs the person twice. We don't do that in high performance. We really just focus on compressions and defibrillation. And it'll make more sense in a little bit. Or right now, I guess. So the idea is that when you're doing compressions, right, we're trying to become the patient's heart. I don't know about you guys, but my heart doesn't stop beating every 30 seconds to take 2 breaths. If yours does that, let me know. But the idea here is that when we're doing CPR, we're trying to maintain a blood pressure that will sustain life, right? There's too low of blood pressures. We need their blood to be circulating effectively. So let's say that this is the blood pressure necessary for life, way up here, by the edge of my screen. And then here's where somebody is when they're dead, right? No blood pressure whatsoever. 30 compressions, 2 ventilations. 30 compressions, 2 ventilations, right? It never reaches that point. And as soon as we stop compressing, it just falls right back down. So our goal with high performance is just continuous compressions so that we stay above that blood pressure the entire time, okay? And then if we have to stop, we've got a lot of headroom before it gets down past that point. We've started to use this idea of pit crew style EMS or a pit crew style CPR, where every person on that call working that cardiac arrest is going to be doing something. They're going to have a job, and every 2 minutes you're going to switch. So Heba, you ask, do you have somebody else doing breaths while somebody is compressing? Hopefully. It depends on how many people you have. If you are by yourself, just do compressions. This is what CPR, high performance CPR is going to say. If you are by yourself and you can't give ventilations or you don't have another person, just do compressions. Okay? So you can see at the bottom here, we have less emphasis on breathing for them, less emphasis on oxygenation. Because we found through studies that it doesn't really matter in CPR. It doesn't help. What it does is it takes away our focus on providing good quality chest compressions. If we can continually circulate their blood, they don't need to be ventilated, right? They're still getting some oxygen. Their blood still has some oxygen in there. So that's what we're going to focus on. And the goal is to maximize everybody that we have and keep a fresh set of hands on the chest at all times. One thing that you don't necessarily get about CPR by watching it is that it's tiring. It is challenging to do good compressions for more than like a minute and a half. You would be surprised. So this being said, if we have more than 2 people on scene or more than 1, right, we'd never let anybody do compressions for more than 2 minutes at a time. Because the quality of your compressions, no matter how much you work out, no matter how many protein shakes you drink, are going to decline after 2 minutes. I have seen jacked firefighters, people who spend their like all off days in the gym, get winded after 1 minute and 30 seconds of CPR. And I have to say, sir, we need somebody else to do compressions, right? That's what our goal is. So every 2 minutes, we're going to switch. And it's going to look like this. So in order, we're going to fill the positions around this patient by their level of importance, essentially. So if somebody's in cardiac arrest, the first thing we're always going to start with is compressions. Okay, and then every other person who shows up to help is going to filter in by the next most important job. So one person starts compressions. The next most important job is using an AED. So while one person continues compressions, this person is going to set up and apply an AED, a defibrillator, to the person's chest, and they're going to hit analyze. Now, this is the minimum that we need to run this call. If we only have 2 people and this is what we have, we're going to do what we can. We want more people, but this is how we're going to start most of the time. So one person starts compressions. This person puts on the AED. Now, we're only allowed to stop doing compressions, or we try to only stop doing compressions when the AED says analyzing, because we're not supposed to touch that patient, right? When this is picking up the heart rhythm, we don't want our hands on the patient. So this is our perfect opportunity to switch. And the AED is going to analyze every 2 minutes. So position 1 does 2 minutes of CPR. When the AED says analyzing, this person is going to stand up. They're going to switch over, or they might not have to stand up. They're going to start compressions, and the other person is going to start managing the AED. So every 2 minutes, the person doing compressions gets a 2-minute break to keep them fresh. Now, if a third person shows up, they will go to the airway, but their priority is not going to be oxygen. It's going to be managing, clearing, and keeping it clear, essentially. The only time we move to doing oxygen is if there is at least an advanced EMT or a paramedic on scene, and they have inserted what we call an advanced airway. Okay, that's the only time we're going to worry about ventilating a patient during high-performance CPR. The reason being is an advanced airway is going to go down at least into their throat, or if a paramedic intubates them, it's going to go into their lungs. So we don't have to worry about any wasted oxygen. We're just going to be giving it right in. Okay? So for you at your level, if you're working a cardiac arrest with just an EMT, do not worry about ventilation. Just worry about compressions, continuous compressions, and AED. Now, as more people start coming, because cardiac arrests will draw a lot of resources, we're going to filter them in these other positions. And we're going to stack anybody extra that we have on position 1. So essentially, I'd put my more experienced providers at the airway, at the AED, and at medications, and then I would line anybody who's showing up on position 1. So every 2 minutes, they just go to the end of the line and the next person shows up. It's really nice to have like a line of 7 firefighters waiting to do compressions, because you don't have to worry about your crew getting tired. You can have hands on the chest at all times, and as like an advanced provider, I can start worrying about ventilations, I can start worrying about medications, right? If any of these things go away, we're always going to keep the position 1 and the position 2. All right, so that's the idea here, is that at each position, every 2 minutes, we're going to rotate so that there is a fresh set of hands on that chest at all times. Now, and let me tell you a little information about high-performance CPR and why it's so cool. With 30-to-2 compression to ventilation ratio, right, if people who receive 30 compressions to 2 ventilations after a cardiac arrest, they had about a 10% chance nationally of surviving more and living more than a year after their cardiac arrest. So, not very high. With high-performance CPR, the people have a 40% chance of surviving a year after their cardiac arrest. It's just an insane statistical jump, okay? Now, if you don't believe me, here's another story from Vermont. This happened in 2016, I think, in Richmond. A police chief was in a high-speed car chase on the back roads of Vermont. While he's following this guy, he has a heart attack. And he pulls his cruiser off to the side of the road, and he goes into cardiac arrest. He is able to let somebody know, hey, I'm not feeling good, and he pulls off. He dies. He has a cardiac arrest in the front of his car. Other officers pull him out, they start CPR, and the ambulance was on standby anyway, so they start coming. There's a paramedic and 2 EMTs. They pick up the police chief, and they start doing high-performance CPR. This is one of the first cases we had of high-performance CPR in Vermont. They have about a 20 to 30-minute transport from where they were in Richmond, and they are just doing continuous compressions the entire time. They have an AED on. I think the medic gave a few medications, but they weren't ventilating, and they were just doing compressions the entire way. About 10 minutes from the hospital, they are doing compressions, and the police chief opens his eyes, and he starts looking around. And so they say, Chief, if you can hear us, blink twice. And he goes, right? So they take their hands off of his chest, they stop doing compressions, they check a pulse, and they look at the monitor. As soon as they stop doing compressions, he went back unresponsive, he has no pulse, and the monitor says asystole. They did such good compressions that they brought his blood pressure up enough to support consciousness without him actually having a heartbeat. They literally became his heart. With their compressions, they brought his brain back to life without a heartbeat. That's just insane. Now, he was still dead. They weren't done, right? They had to bring him to the hospital. That guy's still alive. He survived. But that really shows us why these style of CPR is so important. We don't care about the ventilations anymore because our heart doesn't stop beating every 30 seconds. We need to do continuous compressions as best as we can for as long as we can. Pair that with an AED, and that is our best case scenario. If you wanted to look into it, here is a study about high-performance CPR. One of the things about this is it is still a pilot program. So Vermont has decided to do this, but if you go to other states, you will not be trained in this, depending on what they do. So you will have to fall back on your AHA standard, which we are going to certify you in, 30 compressions to 2 ventilations if you leave the state and you want to work somewhere else. But in Vermont, if you're going to work in an ambulance service, you will do this. And your service will train you on it. Any questions about that? CPR is constantly changing, and this is the first time it's changed for the better in a really long time. Cool. So, compressions are great, but they only help bring somebody back to life if we've got an AED. So, what these are essentially pocket defibrillators. So what you see in Grey's Anatomy in the movies where they've got those paddles, right, and they hit the buttons and they shock them on the chest, it's essentially that, but it's automated. It gets to do it by itself. It doesn't need somebody to read the heart rhythm. It's a computer. It knows how to do it. It's also very easy to use. These were designed for, lack of a better word, dumb people, or people who are not medically trained. Okay, the reason being is they make it as easy as possible to use. So you look at an AED, it has a big green button that says on. When you hit it, it talks to you in very slow, concise terms, right? Remove clothing from patient's chest. Apply pads as shown in the pictures, right? It says it so you cannot mess it up even in the most stressful situations. Now, I'm being mean to people. It's made so that people in high-stress situations don't have to think. It tells you everything, right? Even EMTs who are seasoned, on a cardiac arrest call, adrenaline's running, they might forget things, okay? So what it's doing is it's going to use the electrical signals that our body transmits. So we're going to place pads on their skin, onto their bare skin, and it's going to read their heart rhythm. Now, what it's looking for are those 2 rhythms I talked to you about earlier. Ventricular fibrillation or ventricular tachycardia. Essentially, these are 2 rhythms that the heart is just moving around and it's not doing anything. VFib looks like this. The heart's just kind of twitching, looks like a bag of worms. And then VTAC is when the ventricles, essentially the bottom of the heart, are beating way too fast to even let any blood in or out. So essentially, it's just like an airlock. Nothing is getting in, nothing is getting out. So when an AED picks these up, it will say, hey, this person needs to be shocked. I'm going to charge myself, and then when I'm ready, I'm going to let you know, and you just hit the button, and then I will deliver a shock. Hopefully, that shock is going to reset the heart. Remember those nodes? The SA node and the AV node? It's going to just slap them in the face, and it's going to hopefully get a regular rhythm going again. So that's the goal. We hope that we have one of these rhythms. And if we don't, hopefully compressions will prime the heart enough to go back into one of these. When it's asystole, we do not shock. All right. This is also the only rhythm that you will be allowed to determine. Because even myself, as an advanced EMT, this is the only rhythm I'm allowed to determine unless I get extra training to like read EKGs, because it's a flat line. Because it's one-dimensional, right? Super easy. So if you see anything like that, do not tell the AED to shock. All right. So now we've arrived on scene and we need to check to see if somebody needs CPR. We're gonna start just like we would do everything, right? What's the first thing we do on scene?
Assess if the patient is conscious, alert, and responsive?
No. What is
No.
the very first thing? Yeah,
See?
Brienne. Scene safety. I didn't put it up there, right? It was a test of your knowledge from yesterday. We always make sure the scene is safe. If a person is in cardiac arrest, is there something on scene that is going to put us in cardiac arrest? Okay. After that, we'll walk right into the patient. We make sure it's safe. We'll put our protective equipment on. And then we're going to check to see how they're doing, right? We're going to do what we always do. Hey, are you okay? If they don't turn and look, we'll go down and touch them, give them some pain response. If they don't respond to that, we're going to immediately open their airway using a head tilt chin lift, unless we think it's trauma. We're going to check their pulse and look, listen, and feel for breathing all at the same time. Really simple. We just open. You're going to put your ear right next to their mouth. You're going to put your finger on their pulse, and you're going to look down at their chest to see any chest rise and fall. Again, if you see any gasping, like that agonal respirations, it's not breathing, start CPR. All right? So in general, if you recognize that somebody needs compressions, you're going to want help. So if you're by yourself, call 911 immediately, put them on speaker, and start compressions. Or call your backup, whoever it is. Tell them you need an AED. If you don't call for help, you're going to be doing compressions for way longer than 2 minutes, and that person's chances decline. Okay, so start those compressions, but make sure you have help coming. Now, just because somebody's heart is stopped, they're unresponsive, they're pulseless and not breathing, does not mean we will do CPR on them. Okay, there are certain situations where we will have to determine somebody to dead. Okay, they are not viable for CPR. That is times where there are injuries incompatible with life, like there is no blood in the body to circulate. There is no heart to compress. There is no brain to rewake, right? It's really dire situations like that. We're not going to start CPR. Okay, so that is called the factors of death. We need to assess for these before we start CPR, not only so that we are not wasting our time on doing compressions, but also so we're not hurting ourselves doing compressions for a long time on somebody who doesn't need it. It'd be too traumatic. Okay, so if anybody is actively decomposing, do not start CPR. If they have mold, if they are bloated, if they really have any sort of like decomposition smells, don't start CPR. Okay, they have probably been dead for days, if not weeks. If somebody is decapitated, so if their head is no longer on their body, or their spinal cord is internally disconnected, that is possible to have something called internal decapitation. If somebody was killed by being burned, okay, so if they are incinerated, we're not going to start CPR on them. If when we start to assess somebody, they have something called rigor mortis, which essentially is all the muscles or some of the muscles in the body becoming rigid after death. So it's really telltale if somebody's laying on the ground and you like lift up their arm, somebody who's dead, it'll flop down. But if they have rigor, it'll stay like that. And you might have to like wrestle to open their hands and they'll stay just like this. Okay? That's called rigor. Rigor mortis. That means they've been dead for too long. Another thing that you want to look out for is something called lividity. This is a really large bruise, essentially. It's the blood pooling at the lowest point of somebody's body. So if somebody died and they're laying on their back, we want to roll them onto their side to check their back. Because if we see a big purple splotch, essentially, Anywhere where their body was lowest, that means they've been dead for too long. Going to your questions here. Yes, we are going to keep doing compressions if we see asystole. The AED will tell you no shock advised, start CPR. And then, Isabel, it is pretty challenging to determine that in the field, determining if somebody is internally decapitated. Most of the time it happens at the hospital. So for the most part, I'd worry about, visible decapitation. We don't have x-ray vision. It's really hard to tell completely. So let them decide that at the hospital, but it is possible. Okay, so then the other thing that Vermont does a little bit differently is if somebody went into cardiac arrest because of trauma, because of blunt or penetrating trauma, so getting hit by something really hard, a car, a weapon, right, or being shot or stabbed, if somebody died because of trauma, we're not going to start CPR, okay? Reason being is likely due to the fact that trauma causes physical damage, and organs that are completely damaged will not be receptive to life. Okay, so essentially if you see any injury that's incompatible with life, exposed brain matter, gunshot wounds, stab wounds, and the person has no pulse and is not breathing, we're not going to start CPR. And that's a tough thing to do, but we need to assess these things because if you start CPR on somebody with one of these, there's no chance they're coming back. So save yourself the time, let them die in peace. So, CPR is indicated if we check no pulse or if we feel no pulse, don't get any breathing and they're unresponsive, and we don't see any of the factors of death. We're going to call for help, put our gloves on, and start CPR. Now, these are the important factors of CPR. This is how we do it. You need to compress at a rate of 100 to 120 beats per minute. So, you may have heard like the songs that people like. They're Staying Alive, Another One Bites the Dust. My favorite song to do CPR to is the Imperial March from Star Wars. The da 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 da. It's perfectly like 110, and it's all downbeats. And you think I'm joking, but it will help you keep a tempo in your head if you think of a song. And I'm looking up the Spotify playlist that's songs to do CPR to. Just to give you an idea, there's some, Baby Shark is a CPR song. Black Betty. Dancing Queen by ABBA, right? So there's some real bangers in there. You don't have to choose the ones that I tell you. Pick out your own CPR song, put it in your head, and do CPR to it. Oops. Next most important thing is we have to compress the chest deep enough. We have to go at least 1/3 the depth of their chest, or at least 2 inches. Okay, so on a guy like me, let's see if you can see it, probably about here. Okay, so you need to compress very deeply. You need to get through the muscles, the ligaments, and the bones. Okay, you need to compress the ribs. That may make you think of a thing that you've heard. I'm sure a lot of people when they teach CPR, they say, you're not doing good compressions unless you break ribs. That's true. Okay, they like to say it because it's true. Now, let me clarify something for you. Nobody in the world, not even you, is strong enough to do compressions on somebody and like shatter their ribs and send shrapnel flying and get like stab into their lungs and all this stuff. Okay, that doesn't happen. What happens is the ribs flex out at the sides. So they do something like this. Every time you compress, they will crack and they'll creak and they'll flex. They adapt to it. All right. So after you do compressions for the first couple rounds, it'll get much easier as the bones kind of become malleable. In the first couple compressions, you will hear sounds like cracking knuckles, cracking cartilage. Doesn't matter. Keep doing CPR. I would much rather wake up with broken ribs than not wake up at all, right? Also, they're dead, so they won't feel it. Okay, compress deep enough. Now, on the other end of that, we have to let the chest recoil back to its normal position. If we just squish the heart down repeatedly, we're not going to let it fill. We're not going to have anything to push out again. So, we are going to push down and let the chest recoil every single time. All right? So that's the challenge, keeping that tempo, compressing deep enough every time, and then also recoiling every time. So on Saturday, this is going to be a big part of our hands-on learning. We're going to practice our skills, and we're going to learn how to do it best. How do you place the AED patches on a pregnant woman? Just like how you would on a non-pregnant person. And we're going to talk about that in a minute. And then, do you do compressions with no clothing in the way, like the AED? So you can do compressions through the shirt, but as soon as that AED arrives, we need to get down to that person's bare chest so we can apply the patches to their skin. This is one of those calls where you're basically going to take the patient's top of their clothing off as quickly as you can, because wasting time trying to remove clothes to get an AED on is tough. That's why you see a lot of EMTs, one of the reasons, carrying these around, right? Trauma shears. Oh, look, they're the same color as my green screen. That's funny. They just take it and they cut the clothing right up the front and then open it so we've got access to the chest for the AED. So, that being said, right, we're going to have to try to preserve the modesty of our patient. Every piece of clothing on their torso needs to come off. There are plenty of clothing in them that have wires, like wire-lined bras, jewelry, things with just like little bits on them, right? We can't risk it. Electricity goes through metal. Okay, so we need to remove the clothing. If you have enough people, it does benefit, and especially if you're in a public place, to assign some of those people to like hold up a towel or a blanket so that bystanders won't look. But in general, get ready to be recorded as an EMT. There are definitely videos of me from when I was on duty, on calls, floating around the internet somewhere because, sorry guys, people in this generation record everything. It's not illegal for them to do it, so kind of get used to it, right? If it's a big enough situation, law enforcement will be there and they will be controlling the scene. If people get too in your way or stop you from doing CPR, right, that's a whole other situation. That doesn't really happen. But yeah, we're going to try to protect our patient's modesty. But again, I would much rather wake up in the hospital with images of me online, half naked, getting CPR done on me, than not wake up at all. All right. So what we're not going to do is waste time removing jewelry that's not in our way. A necklace will not really be in our way. We can throw it off to the side. It's going to be behind their head. It's not going to be in our way. What we do want to take time removing is anything that's going to be big enough to be touching us after we shock them, could potentially be touching our knees or anything like that. So if they're wearing really big bangles like chains, I'll take those off. Those shouldn't be hard to remove. But if it's a choker, if it's just like a standard necklace, I'm not going to worry about it. What I'm going to worry about is wire in clothing, especially wire-lined bras. If somebody cuts a bra and opens it and they're kneeling on one of those wires, even if they're not touching the patient, we shock the patient, they're going to get shocked too. So that's why we have to take extra care. No, yeah, there's no need to remove pants in a CPR situation. There might be a reason if an AEMT needs to do like an interosseous, like we might cut up to their leg, up to their knee or their femur. But no, there's not really any situation for CPR where we need to do that unless they're wearing a onesie, right? We just need to take off the top layer for the AED. So this is what an AED looks like, right? This is what you'll see in most public places. Every public building, every school needs to have at least one AED. So what I'd say now is, just like how you might take a look around for fire extinguishers, when you're out in public places, just look to see where the nearest AED is. They'll be in a box like this, and they'll have one of these signs. Usually, they're near doors or lobbies. There's that big green button, right? You just press the button to turn it on, and you can follow all the helpful little pictures and the voice that it tells you. Now, how we're going to apply it is pretty simple. We want to essentially create a straight line through the patches, through the heart. Okay, so this one is going to go onto the right chest. So it's opposite for me, I think. I'm holding on my right side, but I'll do it this way for you. So we want to put it on the right side of their chest. The other one is going to go on their left flank, so that the patches create a straight line through their heart. Just like that. Now, it's just a positive and a negative lead. So if for some reason you just swapped the pads, not a big deal, but it is a huge deal if you do it on the wrong side of the chest. If you were to put the negative up here, and the positive on the right, that would not go through the heart. Okay, so this is the best possible case scenario. If it's a child, they have child pads that will go in the exact same places. They will be small enough to fit. However, if you only have adult pads and no kid pads, you can put one on the front and one on the back, essentially make a baby sandwich. Okay? You can use adult pads on kids, but you cannot use pediatric pads on adults. Okay, so adults can go adults and kids cannot do adults too. So once we apply the AED and we turn it on, it's immediately going to say analyzing heart rhythm. That is our sign. Anytime it says analyzing, we're going to immediately take our hands off the patient because we could mess with its reading. If we're doing compressions when it's reading, it might register a heart rate. It could also pick up your heart rate through your skin from touching that patient, and it might be confused. So anytime that AED says analyzing, every 2 minutes, hands off the patient. And that's when we're going to use the time to rotate the compressor or swap anybody else out who needs it. Once it reads the heart rhythm, it'll either say no shock advised, meaning that either there's a heart rhythm that's normal or asystole. So if we hear no shock advised, we're going to give a quick check for a pulse. If we feel nothing, we're going to start CPR again. If we do feel a pulse, that's a whole other story. Now, if it detects it needs to do a shock, it will say shock advised charging. Now, what that does not mean is to hit the shock button immediately. Okay, if we hear charging, we're going to do 30 compressions. We're going to count out loud. We're going to do 30 more compressions because that shock will only be delivered when somebody hits the button. Okay, so we're going to prime the heart. We've just stopped to let it analyze. That pressure is falling. We hear shock advised. While that AED is charging, we're going to do 30 more compressions so that when I get to 30, I'm going to take my hands off. The person's going to look around to make sure nobody's touching the patient, say clear, and they're going to hit shock, and then we're going to jump right back into it. Okay? Let me make sure I'm not seeing anything. So public areas both have an adult and pediatric one. It depends on how cheap or how frugal the location is. It's just required to have adult pads. I don't think it's required to have pediatric pads. Many reasons. Kids don't go into spontaneous cardiac arrest nearly as frequently as adults do. And you can use adult pads on kids. So they usually just have 2 sets of adult pads. Now, just like an EpiPen, AEDs, if they're not handled carefully or appropriately, can be dangerous. So, what situation, what location, what event might make an AED dangerous to use? Absolutely right. Water. First things first, water conducts electricity. I learned that from Pokemon in 1996. And if we're in a puddle and we shock a patient, everybody touching that water will receive the exact same amount of shock, which is enough to potentially put somebody in cardiac arrest if they're healthy. Okay, so we do not want that to happen. If your patient is in a puddle, move them. Move them to as dry an area as possible. If their chest is wet, that is not a danger, but we do want to make sure that it's dry enough where there's no big droplets or puddles of water on them. It's not going to hurt us, but if there's a bunch of liquid on their chest and we shock them, the electricity is going to go through the water on top of them and not through their body. And if they're wet, the pads won't stick. So move them out of a puddle and then dry them off nice and dry. They don't need to be bone dry, and then apply the pads. If it's raining, that's fine. As long as a puddle isn't forming underneath them, right? It's not going to transmit through the rain drops. It will start to transmit through a puddle that's forming. So if you can, get somebody with an umbrella to stand over you, right? If you have that. But in general, doing it in the rain is fine, but you might need to readjust if puddles keep forming. Try to move up out of grass. Try to move up, to a top of a hill instead of a bottom. Just move away from where puddles form. Now, we're in Vermont. Rain and the lake and rivers aren't the only type of water we have. What about snow? Can we shock on snow? Snow's water. Is it? Yeah, we can shock on snow. Because crystalline water, frozen water doesn't conduct electricity. I have shocked somebody on snow before. Totally fine. Okay. What else conducts electricity, though? Metal. Slush. Slush would, I'd say, because it's a combination. I wouldn't trust it. Good powder snow, packed snow, ice snow is fine. Move them out of liquid. And yeah, you guys are all right. Metal. If you're on a metal floor, don't shock them. You're going to shock everybody who's touching it. If you got rubber bottom shoes, you'll probably be okay as long as no other part of you is touching that metal. So again, just move them away. Move them to a different place. Do you worry about hypothermia if you're out in the snow for too long doing CPR? The person's dead. No, they don't have a heartbeat, right? Our first priority is getting their heartbeat back. Once we have that, yeah, I'll start worrying about hypothermia. But we're preserving a corpse. What do we do to meat? We put it in the refrigerator. It's actually probably better. There was, for a while, a study going on where if we got somebody back from cardiac arrest, we returned a pulse, that we were supposed to pack them in ice. The data didn't support it, but it was the idea that you keep them cool, their brain tissue will survive longer. So, no, I'm not going to worry about it until I get them back with a pulse. Okay. There's some more things to worry about. If you shock somebody in electricity, if you're touching the patient while somebody shocks, bad. Okay, you'll look like this guy. Now, another thing to worry about is medication patches. Now, plenty of people wear these for multiple reasons, like nicotine patches or pain fentanyl patches. There's a bunch of different medications that can go through the skin like this, but we just want to make sure if we see any, that we remove them with gloved hands so that we don't get any medication in our system, and then we just wipe away any residue with a towel. The reason being is that sometimes these can be flammable, and if we shock somebody with one of these on, it could catch on fire. And we do not want that. All right. Another thing to be considerate of are implanted devices like an internal pacemaker or an internal defibrillator. So some people who have heart conditions might have an implanted device like this that either acts as a defibrillator because they have sudden like VTAC all the time, and if they go into cardiac arrest, they just have a quick shock, or they have something in there that just helps to keep their heart regular called a pacemaker. Oftentimes, these can be put under the skin of where we need to apply our patch. They're usually right up here, right? So if you see a circle, an oval, or a square implant, don't put the patch right over, just move it down. Keep it on the same side, just don't put it directly over that device. This is one of the only times you could make somebody more dead, okay? Is if you shock an internal pacemaker or defibrillator, they can explode. So, good news, just don't put it right on top. Just move it down. Everything's going to be fine. Your patient won't be more dead. Now, I saw somebody in the chat say this earlier. Yes, it is a big consideration. Chest hair. Now, I'm sorry, I did have to use a picture of myself. I just cut the head off, okay? But chest hair. If somebody has an incredible amount of chest hair like this, or like me, right, the pads might not stick. And I have seen this happen, where somebody had chest hair just like this, really thick, really fine. I came as the second crew to a cardiac arrest, and they had applied the patches. The AED picked up the heart rhythm, even though it wasn't completely flush to the skin. It was resting on top of his thick layer of hair. So it said shock advised and charging. When they hit shock, I watched as a big plume of flame went across his chest and melted all of the chest hair. It melted the patches, smelled terrible, and the guy didn't survive. Okay? So, if somebody has a lot of chest hair, don't play it like, just don't say, okay, it's going to be fine. Remove it. All right? Most AEDs come with a little Bic razor or a little tiny razor blade in it. Shave a spot for the AED pads. All the ambulances that I've ever worked on will carry like handfuls of plastic little razor blades so that we can shave a spot if we need to. Now, if you don't have a razor or the AED doesn't come with one, but it does have 2 sets of pads, put the first set down, rip it off like a wax strip, and then put the second set on. Okay? They are dead. They are not going to feel it. Take it from me. I would much rather wake up looking like Steve Carell here in the hospital, alive, with patchy chest hair that some EMT ripped off, okay, than not wake up at all. All right? You will not be able to shock them with too much chest hair. Remove it. Exposed blood affect the pads. Yeah, if somebody is bleeding really heavily and we're doing CPR on them, we need to stop that bleeding first, and we need to consider whether or not we should be doing CPR in the first place. Remember, if they are dead due to a traumatic injury, we don't really want to start CPR. If they're covered in blood, that's just like being covered in water. How big should it be? Pad size. Yeah, you don't need to shave their entire chest. You don't need to give them a salon treatment. But just enough so that the pads are sticking to the bare skin of their chest. Okay, so before we take our break, just a couple more things about Vermont-specific cardiac arrest work. We also have devices in the back of the monitor, the back of the AED, oh my gosh, the back of the ambulance called a monitor, which functions as an AED as well as an EKG machine. So it will pick up heart attacks, called STEMIs. If you're with a crew and a monitor picks up a STEMI, we are going to send that to the hospital. Their monitors can send like files over cell phone service, and we will send the hospital a picture of their EKG to let them know that they're having a STEMI. We're going to do something similar with trauma, right? So that the hospital has time to call in everybody that they need. They don't 24/7 staff people who could do immediate heart attack surgery, but they are always on call. So if for some reason one of these happens, we call the hospital on our way and say, we've got a STEMI coming, I'm sending you up the EKG. They're going to put out the tones for all of the doctors who are going to be in the surgery room to get to the hospital. Okay, so that's another thing to consider. Now, like I was talking about, in Vermont, we do CPR for 20 minutes on scene. We're going to continue to do CPR, and we're going to transport them if we get any shocks at all with the AED. So in those 20 minutes, if we shock them one time, they're going to get transported to the hospital. But we're still going to do it after 20 minutes. We're going to work them on scene, and then we're going to start transporting. We're going to continue CPR in the back of the ambulance if necessary. If we're doing CPR for more than 20 minutes, we do not get any shocks. The AED basically says no shock advised like 5 times. We're going to do something called, or ask for something called, termination of resuscitation. So this means we have the potential to start CPR on somebody and then stop and essentially declare them dead. Okay. Here's what the Vermont protocols say. If you wanted to take a look exactly at it, this is for the EMT. And again, I highly doubt that you as a VEFR will be put in charge of this or making this decision, but you do need to know in case you're working with an EMT or higher, because this is something that they might start to do. Okay, so essentially, if we've done everything that we can and there is no change in the patient disposition, their heart is not receptive to shocks, even though we've been doing good compressions, we'll call a doctor at the hospital. We'll tell them everything that we've done. We'll give them a rundown of the call. And then we're essentially going to say, I'm asking for termination of resuscitation. If the doctor thinks that's okay, they will say, yep, that's fine. You can go ahead and terminate. Otherwise, they will say, no, actually, I'd like you to transport the patient. Please bring them here. Okay, so it's ultimately up to the doctor. But most of the time, if we're not going to transport somebody, the doctors will agree. All right? So this is a tough situation because we've just done 20 minutes of work on somebody, oftentimes being watched by family members or loved ones, and then we are going to stop, and we are going to have to be the ones to tell the family members why we're stopping. Okay, this can be one of the more challenging parts of the job, is dealing or talking to the family members before and after, especially on situations like cardiac arrest and where death is involved. Okay, first things first, it's very unpredictable how people are going to respond. Okay, the pretty typical responses to immediate grief are either just appreciation or confusion, denial, potentially anger. Okay, it's not necessarily directed at you. It's all internal in that person, but we just want to keep that in mind, all right? There are a few things that we need to convey to these people, regardless of how they're treating us. But in general, just picture, right? Somebody just told you that a loved one of yours died and they're talking to you. It's probably not going to be the easiest conversation. Okay, so what I try to do is try to give them as much information as possible while being honest and caring at the same time. But we do have a couple things we need to say. Okay, so here's an example of what I say. Oh, where to go? Here. So when we arrived, we discovered that your loved one was unconscious, was not breathing, and they did not have a pulse. We immediately began all efforts to try to resuscitate them, but after providing continuous CPR, breathing for them, and administering medications, there was no change in their condition. I have spoken to the doctors up at the hospital who have assured me that we have done everything they would do, and I am sorry to inform you that your loved one is dead. Okay? It is very important, even if it feels mean, to include some form of the word dead, died, killed, not alive. Okay? You can't say your loved one has passed on. Your loved one is in a better place, because that is not necessarily the case, right? We need to tell them exactly what happened. You would be surprised, but if you said your loved one is in a better place, some people would say at the hospital, right? Like up at the hospital with the doctors and they're alive, because that's a better place than here. You brought them to the hospital. And you're going to have to say no, and then they're probably going to get mad, okay? You have to say, as compassionately as possible, this person is dead. It's tough, but they need to hear it, all right? They need the truth, even if it's tough. It's tough for us too, so just consider that, all right? It's not going to be easy, and I definitely did not do this well the first time. It takes practice, takes a lot of time working with people, all right? So let's take a break. It's 6:34. Let's come back at 6:50. I'll give you 15 minutes, and then we will finish off our last lecture. See you in a minute. All right, so welcome back. I won't do that again. I won't pretend to be a baby. So on an infant like this, our CPR is going to be a little bit different. We're not going to be able to put our hand in the center of their chest and compress. Okay, it's too big for that. So there's two ways that we can do compressions on an infant. All right, if we're by ourselves, we are going to do something with our two fingers. Okay, we're going to find the baby's sternum right here, and then we're going to compress just like this using our two fingers. Okay, it's the same tempo, 100 to 120. Needs to go 1/3 the depth of the chest. Needs to recoil the entire way. All right. The other way that we're going to do it is with our two thumbs in the center of their chest like this. We call this a video game controller technique. Okay? We're going to do this when we have multiple people with us helping. The reason being is that infants and kids will go into cardiac arrest not because of heart issues, but because of airway issues. Usually it's because they choke or they suffocate or something along those lines. So we will be doing a little bit of extra ventilation with kids. All right, so if it's an infant, we are going to want to do continuous compressions, but we will be ventilating them once every 10 compressions. Okay, so we're going to practice this on Saturday, but I just wanted to demonstrate that. You can't just put your hand in the center of their chest. You have to use either two fingers or your thumbs. All right? Thank you. Let's get back to it. So we talked about what happens when somebody doesn't make it, but what do we do if the patient gets a pulse back? Where do we start? Oh, I should probably be looking at the chat, huh? Give air. Okay, that's one possibility. Yeah. We're going to start over, okay? Because now, this isn't the same patient that we were working before. This is now a very sick, but alive patient. Beforehand, when we were just doing compressions, we didn't have to worry about why necessarily. They were in cardiac arrest. We just have to bring them back. But once they get a pulse back, we're immediately going to start over. We're going to start with our ABCs. We're going to check to see if they need oxygenation. We might have to ventilate for them. They could have a heartbeat back, but they might not be breathing on their own. So we might need to ventilate them. We want to check their vital signs, get a blood pressure and stuff. We're going to be talking about that, but you will only be able to do a second set of vital signs after a licensed EMT. Another really good thing, if you're in the back of the ambulance, would to be getting an EKG. So taking a picture of their heart using the monitor. Again, if you join a service, they will train you on how to do that. So we're going to start right over. Now, the other thing is that if somebody comes back from cardiac arrest, the chances are they will go back into cardiac arrest. So oftentimes the way people are saved is not just from like one shock and then waking up being like, it's a repeating, okay, we've got their heart rate back. All right, they're back in cardiac arrest. We shock them again. They're back. We bring them to the hospital. They might do that a couple more times. That's pretty standard, okay? So one of the things I'd do, if we ever get anybody back, is I'm going to designate one person to essentially just keep their hand on that person's pulse, constantly feeling it. As soon as it goes away, we'd start compressions again, but until that happens, we're going to treat them like a very, very sick patient. So that's a great question, Rachel, about joining a service. It's going to depend on the service, whether or not they have online applications. The thing about Vermont is that we are pretty spread out. There are a lot of volunteer services in rural areas, and in places like Chittenden County, this is where the largest population of like paid services are. So places like South Burlington and Burlington, who are career fire EMS with paramedics and 20-year running guys, their need for VEFRs is less because they have adequate staffing that's paid for their area. Places that really need VEFRs are going to be volunteer services. So in Chittenden County, like Shelburne, Charlotte, Colchester might even be interested. Depending on where you are, you might have to look around a little bit. So it will depend on the service. However, most services are super easy. So like, yeah, Colchester is online, right? You could submit an application like that. Some you might just have to give a call, right? And say, hey, is there somebody there I can talk to about volunteer opportunities? So I will be a resource for you after this class. Let's worry about getting you your actual prerequisites for that cert first. But then afterwards, please, yeah, email me and I can help set you up with meetings or something like that for different services. Okay, that's cardiac arrest. Now we are moving on to traumatic injuries. Okay, so you'll remember on our first day, we talked about the white paper, the reason why EMS even became a thing. And it's because of the leading cause of death in the first half of the lifespan, so 1 to 40 years old. It's all blue right up there, and that means traumatic injuries. For the first half of the lifespan, young people, right, 1 to 40 years old, the most common reason they die is due to unintentional injury. Car accidents, traumas, whatever it is, okay? It's still like that. In 2020, we saw a little bit of a change to COVID, but it's right back to unintentional injury. You'll see underneath that, we still have traumatic injuries, suicides, homicides, right? It is one of the most common reasons people die, unintentional injury. And it's the reason we're around. EMS has evolved a lot to also have a lot of knowledge about medical emergencies, but this is where we started. This is what we got our first degree in, was traumatic injuries. Okay, so that's why it's so important to us. It's going to involve heavily our knowledge of the skeletal system. And when we start practicing on Saturday, we're going to do hands-on head-to-toe assessments, where our goal is we're going to practice palpating each other to feel the skeleton, right? We're going to need to know what it feels like to palpate a human healthy skeleton so that if anything is broken, if we're palpating that person, we're going to know what to look for because we know what a good, solid, healthy, not injured human body feels like. Then we're going to be able to easily pick up the injuries. Another major part of the body we need to be considerate of during trauma is the C-spine, right? The spine in general. And we're going to talk about this when it comes to applying C-collars. If we protect the spine, they have a much higher chance of survival because this little part, right, that is what protects our breathing, our heart rate, everything. Protect the neck, protect the back, they'll have a better chance. So here are what we would consider to be significant mechanisms of injury. And that's a fancy word of saying, how did somebody get injured? What caused their injury, right? If I stubbed my toe, the mechanism of injury would be me running my toe into the annoying table, right? But if somebody is injured after a motor vehicle crash, I'm going to say that's pretty significant, right? I don't weigh as much as a car, and I just stubbed my toe a little bit, probably not any major injuries. But cars weigh a lot, they go really fast, and if somebody's in a car accident, there is a high likelihood of injury. Same thing with being struck by a vehicle. Even people falling can be a major sign of injury. That really depends on how old somebody is. If somebody is 16 to 45 falls from a standing height, that's probably not going to be that big of a deal. They might have a couple bumps, depending on how they fall, maybe a broken arm. If somebody over 65 falls, a standing height fall could be the death of them, right? They could hit their head and have an internal bleed. They could break their hip. There's a lot of risks to falling. Blunt or penetrating trauma, right? Gunshot wounds, being hit by something, stab wounds, all those kind of things. Motorcycle crashes, probably worse than car crashes. There's less protection for the patient. People who are try to kill themselves by hanging, diving accidents and driving, right? We have lake in Vermont. People dive all the time. We have the Bolton potholes. We have swimming holes, and all of them can be relatively dangerous. And then also recreational accidents. So there are many, many ways that somebody could be significantly hurt due to a mechanism of injury. Now, there are different types of force, different types of trauma, and that's going to be a big consideration for us when we're treating our patient. What type of force injured them? Was it blunt, right? Were they struck by something in a broader kind of area? Was it like a blunt trauma can be being struck by a vehicle, being punched, right? Getting hit by a baseball bat. Anything that would be a broad area of high impact. So something that breaks bones. Penetrating trauma is anytime something forces its way into the body when it's not supposed to be there. So gunshot wounds, impalings, if somebody runs into something and it stabs them, stabbing, shrapnel, right, from an explosion entering somebody. All of these would be penetrating injury, when it breaks the skin barrier and embeds itself into the body. And now the next two, these are very, they're not as frequent types of trauma we see in civilian EMS, which is like explosion, blast trauma, and then baro, which is what we consider to be like pressure trauma. So oftentimes those two things go together, but if for some reason somebody goes from like a really high pressure to low pressure, it can have some funky effects on the body. So what we're going to be concerned with most of the time is going to be blunt and penetrating, but if there is an explosion, we do want to be considerate of that. Essentially, there are three different ways somebody can be hurt from blast trauma. The first being baro trauma, because an explosion changes pressure. So if somebody's really close to it, it can really hurt their their internal organs that are pressurized. So lungs, bladders, livers, it can really just rupture internal organs. Also, there's a lot of heat right there, so people who are close to a blast, not very good chances. After that, if they're farther away, we're going to have secondary injuries. So this is things like shrapnel, things being thrown away from the explosion, potentially hitting somebody. And then the third thing is what we call tertiary. So somebody being thrown and then striking something from that blast. Again, not very common in our area. Now, when it comes to what we see from trauma, I'm sorry, I'm reading the chat. Yeah, so water has a lot of properties of slowing things down. So even bullets, if they're shot into water, they will immediately start to slow down. Depends on the bullet, right? But yeah, if there's an explosion and you get underwater, water can protect you a little bit. It's not like being in a bomb-proof shelter, but yeah, it can help. So when somebody gets injured, One thing that we want to really assess for, especially if they're bleeding, is how severe is that bleeding? What vessels were struck? Because if it's an arterial bleed, from what we know about arteries now, they are high pressure and they are taking oxygenated blood, useful blood, away from the heart and getting it to the organs. So if an artery is punctured, we're going to see really high pressured and fast bleeding, right? You will actually see that kind of movie squirt, right? If an artery is punctured, a squirt of blood will leave in time with each heartbeat, right? And that's only from arteries. It will also be a bright red color, okay? Because it's rich in oxygen. So if you see squirting bright red blood, that is very bad. You need to stop it immediately. Okay, that is an arterial bleed. Somebody can bleed out from an arterial bleed in like less than 5 minutes. All of their blood gone. After that, venous, right? So venous blood is the blood that's returning to the heart. It's going to be a darker shade. And it won't spurt like you see in arteries because it's lower pressure. If somebody has venous blood, it will be oozing or it will be pouring. It won't be spurting. And the speed at which it leaves is truly going to depend on the severity of the wound, how big it is, and how many vessels are struck. Typically, if somebody has like a medium depth, if it's through their layer of their skin down to the subcutaneous tissue and into the muscle, it'll still be venous because all of our arteries are nice and deep down, tucked against our bones. So it's like really deep penetrating injuries will get arteries. However, uncontrolled venous bleeding can lead to death too. So we still need to stop it immediately. Now, capillary blood isn't necessarily something we're going to be so worried about. This is really surface level bleeding. This is where bleeding happens like in our top layer of skin. So you only really get capillary bleeding on your fingers. Like if you get a paper cut, that's capillary. What we're mostly going to see is arterial or venous. Okay? So, big pointers here. Locate where the bleeding is coming from. Check to see if you can tell what type of bleeding it is. If you see bright red blood, arterial. If you see dark red blood, venous. Depending on how much the patient is bleeding, we might need to do a thorough assessment to be actually able to find where the bleeding is coming from. If someone's been laying there for a while, they might just be covered in like sitting in a pool of their blood when we don't know where it's coming from. So this is a time in trauma where we might pretty much, one of the first things we do after verifying all of the priorities is stripping down the patient so we can find all of their injuries. These are those times where we might need to do that, getting them trauma naked as we'd consider, so we don't miss any bleeding. We cannot really tolerate too much bleed, right? We have a set amount of blood in our body, and we need all of it. Really, we can survive with a little bit less. We can donate blood, we can lose some, but if we hit a certain line, it's going to get really bad. Okay? So, for an adult, the danger zone is about 1 liter of blood, so around 1 Nalgene. After that, that means we've lost too much and our body is really, really going to struggle. Kids, it's about half that, about half an Nalgene at 500 milliliters, and then infants, even less. And that's just, all of this is also going to depend on the size of the person. Now, my question to you is, looking at a scene, are we going to be able to estimate the amount of blood that a person has lost in milliliters? Yeah, no. Sorry, and there's a couple reasons for that. One, the surface on which it lands. Would you say that this blood is the same, less, or more than this blood? I don't know. That's the point. You can't tell. If we tried to, we'd have to take into consideration, right? The carpet absorbs, whereas the tile just spreads. So this might look like more, but it might be less than that blood, right? So don't waste your time trying to estimate milliliters. It's really going to be like, did they lose a little? a bit or a lot of blood. That's kind of how we have to determine it. It's kind of weird, but that's basically it. Yeah, they lost a lot of blood. Right? So this is how we stop it. This is a life-saving slide coming up. Pretty straightforward. Bleeding control. Oh, and now I'm blue. So really straightforward, really simple. The first thing we're always going to do is apply direct pressure to the wound. Now, I don't mean put pressure on it to succeed in life. I don't mean make it like stress about its tests. I mean put pressure physically with your body on that wound. And I don't mean just this either, right? You have to apply pressure, and if you can, get it down onto the ground and hold your body weight on top of it. Okay, that blood is trying to run away, and you're trying to keep it there. You need your body to become their skin. Okay, pressure and holding that nice and tight should hopefully stop the bleed. It should stop 75% of blood. 75% of bleeds, right, depending on what it is. So hopefully, that's all it's going to take. Direct pressure with gloves and like a gauze pad in between for about 1 to 2 minutes. That should stop the bleeding. If it doesn't, then we're going to have to jump to something a little bit more useful. If we're applying direct pressure and the bleeding doesn't stop, we're going to apply something called a tourniquet, which is essentially a piece of cloth that you will wrap around somebody's extremity. Now, I'm going to touch on that question in a second, Dylan. Great question. You asked if we could use a belt as a tourniquet. I'll talk about that in a sec. So here are what tourniquets look like. Okay, there's a bunch of different kinds. These ones right here, the black ones, these are pretty much what you'll see on ambulances. Okay, these are called cat tourniquets. Now, essentially what it is it's just a cloth that wraps around the extremity, and then you twist this windlass over and over again, making it even tighter and tighter and tighter. Your goal is to stop circulation below that tourniquet. So if I'm bleeding out right here from an arterial bleed, we're going to put that tourniquet right here. Going to tighten it as tight as it can go, and now no blood is actually getting from my heart to leave that wound, right? I have shut it off. I have made it a faucet. You're twisting that faucet off, right? Bleeding is wasted water. Save the environment. Turn it off. Right? You can see other ones too, like this elastic one, where you'd clip it and then pull it really nice and tight. And you can also see improvised tourniquets over here. Now, Dylan, what you say, that is a pretty common thing people say. Use a belt to do a tourniquet. What I will say to you is that the important part is the twisting, is this windlass. It is really hard to apply a belt tight enough and get it to stay there without something to twist. So what is better to use is actually something like this you see in this image. A cloth and a big stick, or something tight, or something that can be used as a windlass, like shears, right? Something strong that's not going to break. So you essentially just wrap the cloth around that person's arm, tie a knot, slip the shears in, wrap it up so it gets nice and tight, and then tie another knot so it doesn't come undone. A belt won't twist, right? It's leather. It will just rip. If you pull it really tight, it's not getting tight enough. So instead of using a belt, use a shirt, or use parts of your pants. Use something thick too. You don't want to use like a shoelace, because we need at least thickness to wrap around. So yeah, we can practice with it. We're gonna have hands-on real tourniquets. So those are what we always prefer. We don't want to use an improvised one unless we absolutely need to, like we don't have anything with us. So we're gonna practice with these, and we can absolutely show you how to make an improvised one. No, you do not take it off once the bleeding stops. That is doing exactly the opposite thing that we just did, right? Apply a tourniquet. If you take it off, you are just opening them up for bleeding more. So keep it on. Only surgeons and doctors will remove them. Yeah, if the bleeding doesn't stop, we could apply another tourniquet. However, it would have to be above the other one. If we put it below, it won't work, right? So make sure that if you put one on, you can't put one on below it. You need to put it on above it. Okay? You can get a tourniquet at Walmart. You can get it at a pharmacy. You can get them online. They're very easily accessible. Bleeding control kits, probably like $30 some places. I would recommend getting a cat tourniquet. And don't get ones that are like orange or blue. Those are training. Get ones that are black and branded, like this. They say like cat tourniquet on it. These are usually made of metal instead of plastic. And so then another great question, is it dangerous having no blood flow to that area? For a certain amount of time, no. Tourniquets nowadays can probably be left on for about 6 to 8 hours. Usually it doesn't take that long to get to a hospital, but yeah, they can be left on for quite a long time. Now you'll also notice this tab right here. This is actually, you're able to write on with a Sharpie. So the goal here is once you apply the tourniquet, write the time that you applied it. So that when you bring them to the hospital, they have an idea of how long that tourniquet's been on. Okay? The other thing about tourniquets is they're painful, right? Just imagine like cutting off the circulation for a long time on somebody's arm. It's going to be painful, but it's going to save their life. Okay, so remind them of that. The other thing, these can only be used on arms and legs. If somebody's bleeding from their head, do not put a tourniquet around their neck. If somebody's bleeding from their abdomen, do not put it around their chest. Okay, this only works arms and legs. If somebody's like injured and bleeding from here or even the armpit, it's not going to work. Okay, up in the groin too. It needs to be on their legs or arms. So in general, we have to apply a tourniquet 3 fingers above the injury. So let's say I got injured right here, 3 fingers minimum, meaning I'll apply the tourniquet right there. We're not going to apply over joints, over elbows or knees, but also when in doubt, high and tight. So put it up as high as you can on the arm and nice and tight. Okay, but what do we do if somebody is having uncontrolled bleeding from a spot that's not an arm? We have another skill and another tool called wound packing and hemostatic gauze. So this gauze is filled with a chemical called hemostat that prompts blood to clot. It essentially makes blood clot. So if somebody has a wound that we can't put a tourniquet on, we are going to have to take the hemostatic gauze and we're going to have to pack that wound.
Once you've identified a wound, hold pressure, direct pressure, and expose that wound. Go ahead and try to identify the major bleeder or any other bleeds within that wound. We're going to hold pressure on that wound. Open up your combat gauze. Make a small ball. 1 for 1, replace the finger that's holding pressure against the bleed until you've packed that entire cavity. Again, 1 for 1, maintaining pressure while you're packing and ensuring that blood isn't seeping through or around the combat gauze as you're packing it. You're going to continue to pack, maintaining pressure the entire time you're packing. Once you've packed the entire wound, hold pressure over the wound, ensuring that blood isn't seeping around or through the combat gauze. Hold pressure for 3 minutes. Once the 3 minutes is up, and it's time for a pressure dressing.
All right. I know what you're thinking. How the heck is that helping? Right? Yeah, so in that video, he was not wearing gloves. That's okay. It's training, right? We would be wearing gloves. So the reason we need to pack the wound is because hemostat only starts clotting blood when blood flows over it. So if we just put it right on top, we are just going to create clots on top of the wound, and it's still going to fill with blood. What we need to do is find the vessel that is bleeding and get the gauze as close to it as possible so that the blood leaving it will start to clot in the opening to where it's torn. Okay, so we need to pack it down into the wound until it's full, and then we hold pressure on top of that. Okay, we are going to get to practice this on fake legs on Saturday with combat gauze. Okay, very rare situations, but if a tourniquet isn't viable, you might need to use this.
Once you've
Now, other types of bleeding that we're not going to be able to control are things like internal bleeding. right? This can happen oftentimes from blunt trauma, right? Somebody gets struck and internal damage happens, but their skin is still intact, so we don't actually see any blood. We can't apply pressure, we can't pack internal wounds, and we can't apply tourniquets for internal bleeding. So our goal here is recognizing it as soon as possible and getting them to the hospital. So internal bleeding, what we're going to see is discoloration. So you're going to see things like down here, right, where there is blood pooling in that under the skin. It's going to look like a bruise. Edema, that is a fancy word for swelling. So something that is getting bigger, essentially. It's going to get hot, discolored, swollen, and it's going to be rigid to the touch, right? Normally skin compresses a little bit, but if it was swollen, it would be rigid and it would feel like I couldn't press into it. This can happen over the body, right? So this guy is in a really bad way, and you can see the major internal bleeding he has in his abdomen. We can't really do anything about this. These people need surgery, right? So in these situations, we're going to really want to get them to the hospital fast, do a good report, tell the hospital what's coming, and just do whatever we can to keep them alive until we get there. MOI stands for mechanism of injury. So sorry, I didn't include that. Just like we had a, no, we did have the mechanism of injury. So like the reason they got hurt, how they got hurt. Now, internal bleeding from vessels into the general space of the body is going to present like this. There are other places we can bleed internally, like in our intestines, in our stomach, and things like that, okay? So here are some other ways to recognize internal bleeding. Ecchymosis, fancy word for bruising, that's that discoloration I showed. Hematoma, this is a swollen area of direct internal bleeding. So you may have had one before. If you got like an egg on your head, or you just got a really bad bruise and it kind of swole up and it looked like a big blood blister, that's a hematoma, okay? Another fancy word for a bad bruise. Hematoemesis, that just means throwing up blood. So this could mean a bleed in somebody's airway or in their stomach, right? If somebody has a stomach ulcer, they could be bleeding into their stomach, which would cause nausea. And if they throw up, we would see red vomit, blood in their vomit. Hematochezia, this is red poop, essentially, bloody poop, stool. Okay, this can indicate that somebody is bleeding in their intestines. Here's the deal. If we see, or if we assess that somebody has red blood in their stool, that means they are having a lower intestinal bleed. That means it is closer to their rectum, essentially. That means they're bleeding low and they are passing red blood. Now, melena also indicates internal bleeding in their intestines, but it tells us that it is higher up in their system because it comes out like black, tarry stool. It looks like coffee grounds, like spent coffee grounds. And that's because the blood is being digested. So bright red blood means that it's not passing through their stomach and their intestines. It is probably lower in their intestines, but black, tarry blood in their stool means that it is being digested. So this is just a picture of coffee grounds, but that is what it looks like. Okay? So either of these, red bloody stool or black tarry stool like this, is a major sign of internal bleeding. This person could be bleeding out internally over a long period of time and they don't know it. Sometimes this can happen really fast too. Okay, so any sign of internal bleeding, major concern, get them to the hospital. Now, for car accidents, here are some of the most common injuries that we're going to see. Head, neck, and back injuries, chest injuries, arm and leg injuries, and then also internal bleeding. These are the most common things we see for car accidents. And here is an example of why head injuries happen a lot. Our brain is jelly, suspended in liquid, and it's encased by our hard skull. When we're driving a car, we're moving fast, and if we stop suddenly, or we start moving again suddenly, the jello moves, okay? So what I'm demonstrating down here is something called coup and contra coup, meaning that your brain will be injured on the opposite side of where you received the impact. If I get hit here, my brain moves forward and then picks up speed and whiplashes and hits itself against the back of my head, like you can see in this jello. So watch him hit it. The biggest impact of the brain is the reflex back to the skull. So if I get hit in the front of the head, I'm likely going to feel pain here. Versus if I get hit in the back of the head, I'm likely going to feel pain here. Okay? So with head injuries, pain, and especially like whiplash injuries, pain is going to be opposite from where the injury occurred. Here's another acronym for you. I promise this is the last one. Actually, I can't promise it. I think it's the last one. This is just to help us remember what injuries we're looking for in traumatic situations. So again, kind of a lame one. DCAP BTLS. Stands for deformity, meaning anything that does not look normal. That is a deformed femur. Right, that guy looks like he may have like a previous injury or maybe just was born this way. But in general, you look at that, you're going to say, whoa, that's not right. That leg looks broken, deformed. Contusions, another fancy word for bruise. Medicine loves just ignoring the word bruise. Okay, an abrasion. This is the fancy word for like a souped up rug burn or like asphalt burn, right? You've had a bunch of abrasions in your life. If you've fallen off a bike, if you've been running around on your hands and knees as a kid on a carpet, your knees and all that kind of stuff, they get the skin scraped off. So abrasion is when skin gets scraped by a hard surface. So people who fall off motorcycles or off bikes and they slide on the road, these are a lot of the injuries you will see. All right, just a fair warning. Again, there are some gross pictures coming up. The next part of A, this is called avulsion. So an avulsion is when a layer of skin gets sheared. Okay, so something like that. So not necessarily down onto the muscle or anything, but something scrapes and slices the skin so that it comes off like a sheet. Okay, that's called an avulsion. Puncture, pretty straightforward. Something punctures the skin. This one's not so bad. It's just a little dart in somebody's knee or elbow. Could be anything bigger than that too. B is burns. So any type of burn from 1st degree to 3rd. We're going to talk a little bit about burns in a minute. Tenderness isn't the most lame one. It's just when somebody says, ouch. Yeah, that hurts when you touch me there. Ouch. Right? It can be worse than that too. Somebody being like, ow, right? But it means pain on palpation. So somebody's hurting their arm. I start feeling down their arm. No pain, no pain. They say, ow, right there. I'll start feeling it up from the other way. And they say, ow, right there. Yep, that's where their injury is. Tenderness. Laceration means a slice, a cut into the skin. It isn't defined by depth. Anytime there's a cut, a slice by something sharp, that's a laceration. And then swelling, right? If you look at this person, they have a leg injury. You can see that it's red, swollen, probably hot to the touch, where you can compare to this other one, and you can see how it is swollen, right? This one's bigger. So that's what we're going to be looking for. When we're going through our head-to-toe assessment, when we're palpating somebody from the top of their head down to the bottom of their feet, we're going to be keeping our eyes out for any of these things and trying to remember where they are on the body, right? So if I find a deformed left arm and a burnt right leg, I need to make internal notes or write those down so that when I'm transporting the patient, I know what to treat, I know what to tell them. Okay, so burns. The level of burn corresponds to the level of skin that it affects. So we learned that there are 3 layers of skin: the epidermis, the dermis, and the subcutaneous tissue. And so the deeper a burn gets, the higher degree it is. A 1st degree is a sunburn. okay, or a light reddening of the skin. That's the most common one. First degree burn is a sunburn. I'm sure you have all had one. That's when it gets red, itchy, irritated. It just feels hot to the touch, right? It's just annoying. That is a first degree burn. A second degree will go down past that first layer and start affecting the dermis as well. So it gets past that epidermis down to the dermis, so it's getting deeper and deeper into the skin. And second degree burns are very painful because they start to produce what we call blebs, blisters, that are really painful, and they can rupture, leaving openings to deeper into the body. And once we start seeing second degree burns, these patients are at high risk for infections. Finally, a third degree burn is when it burns past the subcutaneous layer, so at least down to muscle. It could even go down deeper to bone. Okay, it is evidenced by charred skin. So black charred skin looks like it was burnt. Now the other thing is, the way heat works is it's usually going to be much more concentrated in a center point and then less concentrated as it goes out. So somebody who has a third degree burn is going to have a spot of really bad burn, and then likely second degree burns around that, and then first degree burns around that. So somebody who has a third degree burn also has second and first degrees, so we need to treat all of it. Okay, here are some examples of burns. Here is a first degree. This is a more severe first degree. That looks very painful. You can see some of the blebs down here for the second degree, and then you can see the charred skin here for that third. Now, I can speak on how painful second degree burns are because that's me. Those are second degree burns on my shoulder there, and they go all across my back and onto my other side too. That was from a weekend of not wearing sunscreen. Yeah, and that was probably one of the most painful experiences I've had in my life. Okay, I applied sunscreen. I just swam a lot and I didn't reapply. So apply your sunscreen. Okay, let me tell you a story. So see that redness on my shoulder there? There's the really bad second degree blebs, those burns, and that first degree around it. So I was on rescue duty the next day, and I was in a lot of pain, and I couldn't like move my arms this way very much. So luckily I was the person in charge, so I could just like direct people to do things, and I was just taking notes, keeping my back as straight as possible. But I took a burn sheet, right, like the treatment we have for burns, and I taped it onto my back just so it would be covering and keeping it sterile, right? After a couple calls, I get back to the station, and one of my friends is like, hey, you're leaking through your shirt. You might want to go change your burn sheets. So I go into the bathroom, and I begin to peel away the tape to remove my burn sheets. And I ended up taking all of the skin off of my shoulders from like one side to the other, because the tape was stuck to the first degree burns, and it'd been a couple days. So when I pulled, the tape took all of the layers of skin with it. So I was in the most pain I've ever been in my life. I like came out of the bathroom and I was twitching and shaking, and I like fell onto the couch and was laying like this. I still to this day thank the universe for Mike O'Keefe, a paramedic who was just stopping by. He literally was just there for no reason, just saying, hey. And he saw me and he's like, how long is your shift? And I was like, I've got 6 more hours. And he's like, no, you don't. Go home. I'm taking over for you. So that saved me. But yeah, wear your sunscreen. And second degree burns really hurt. So if you're treating somebody with them, be kind. They're in a lot of pain. So assessing what type and the severity of the burn is important. But what we really care about and what the hospital wants to know is what percentage of this person's body is covered by burns. I hate math. Okay, I'm not good at math. So that's why we have this rule of 9s to kind of help us estimate. So essentially, this is a way for us to look at somebody and just guesstimate how much of their body has been burned. So if somebody has the front of their arm, but not the back burned, that's roughly 4.5%. But total, that's 9, right? One arm completely burned is 9%. And we kind of go from there. Front of the legs, that's 9. Back of the legs is 9, right? So we just do a little bit of math like that. Now, no, I wouldn't say luckily, I guess, but most of the time burns aren't covering this much of somebody's body. And so instead of being like, okay, like 1/3 of their left front of their left arm is there, that's like roughly this. Another technique we have is something called the rule of palm. So if you take the patient's palm, not their fingers, just the skin right here, that's roughly 1% of their body. So if they have a burn that's like on their forearm here, we do this, that's 2%, right? But you have to use the patient's body. So if it's too small to use the rule of nines, just use the palm rule. So I think I was saying that if the burn isn't covering enough of their body to use the rule of nines, use their palm to do 1% at a time. That's all I needed to say. I don't know why it decided to cut me off. All right. Now, how we're going to treat these burns, we're going to keep them covered, essentially. One of the main reasons people with burns die is not necessarily due to being burned. It is the effect of the burns on the body. If they have higher than second-degree burns, they're essentially just open to infections. Those blebs, if they rupture or if the skin is burned away, they lose all of their protection against pathogens, bacteria, fungi, everything. Okay, so a lot of patients die from infections after burns. The other reason that they might succumb to their injuries is because of one of the main things that skin does for us. It regulates our body temperature. If somebody doesn't have the ability to regulate their body temperature because their skin is burned, they will easily succumb to hypothermia in areas that we would not consider to be cold, or hyperthermia in areas where we would not consider it to be warm. Okay? So one of the things we always want to do is keep them warm, nice and warm, right? Turn the heat up in the back of the ambulance, wrap them in the blanket after we've covered their dressings with sterile burn sheets. There's a special type of dressing that they'll carry on ambulances. In general, we just don't want to put anything dirty on that wound. We could also flush the wound out, the burn out, with sterile water. So on the ambulance, they carry like packets of sterile water. We want to neutralize the burn. So cool it down with some sterile water, dry it off, and then apply the dressing. We used to apply moist dressings to patients with burns, but that ended up making them cool down faster, and that wasn't what we wanted. So now we just keep them nice and warm and dry and sterile as much as possible. All right. When it comes to other burns, like burns in the airway, that's going to be really challenging. We are not going to have the appropriate tools to manage that. They're going to need to be intubated by a paramedic or really get to the hospital quickly. So another thing for you guys, again, you're going to have one of the more basic levels of certification. Do not hesitate, and please just call for extra people. If you're by yourself, you need other hands. Even myself as an advanced EMT, I want people there with me. Do not try to take things on your own. You need to communicate. All right, so enough about burns. Altered mental status we talked about, but we didn't talk about it so much with trauma. Okay, there are plenty of situations where somebody might get struck in the head and have altered mental status. Okay, some of those more common things we think of are things like concussions, which can cause altered mental status, usually in the form of confusion and like not being able to tell the time, not knowing what's going on. All right. Now, it's not within our scope of practice to diagnose a concussion. We're not going to be able to look at somebody and say, you are concussed, but we do want to recognize signs and symptoms. They need to be essentially diagnosed by a doctor. And a true concussion diagnosis is not just one assessment, it's over a couple hours. So we can't do that. They need the doctor to do it. One thing we definitely want to know about, though, is the negative effects of undiagnosed and uncared about concussions, specifically something called CTE, or chronic traumatic encephalopathy, however you say that. Encephalopathy, it's another word I have a tough time saying. But essentially, repeated concussions over and over and over again are showing to have severe neurological deficits on people. Specifically, sports people, NFL, right? There are a lot of cases of former football players who are not that old suffering from dementia because of how many concussions they've had, right? So here's a brain that is normal, and here's a brain that has CTE after death. So somebody who didn't suffer a bunch of concussions in their life and somebody who did. You can see how their brain is severely, severely diminished, right? That is from just constant injury and not rest. Okay, so if you hit your head hard, even if you don't hit it that hard, be careful, all right? You do not need to go unconscious or get knocked out to have a concussion. It really depends on how you're hit, okay? Just be careful if you play sports. So some signs of concussions are going to be brain fog. So general confusion, right? If you've been knocked in the head, you've been like, oh, wait, who am I for a second? Okay, yeah, Kevin, ow, my head hurts, right? People with concussions, it might be a little bit more. Here's an example for you. One day when I was at work, somebody got hit in the head with a weight bar, okay? And they came to see me, and at first they were like, hey, yeah, my name's this. My head really hurts. I just got hit in the head. I'm like, all right. I did a quick assessment on him. I was like, hang here for 10 minutes. I'll check on you in a little bit. Let me just start writing some of this down. After 10 minutes, I came back to him. He wasn't able to tell me his name, wasn't able to tell me what happened, and he didn't know where he was and he was scared, right? So we brought him to the hospital. But it can change. It can increase in severity as time goes on. Other major signs and symptoms, nausea and vomiting. Somebody getting really nauseous or maybe throwing up after getting hit in the head. Sensitivity to bright lights, photosensitivity, like bright lights hurt their eyes. Loud sounds might hurt their ears. That's that fancy word, hyperoxis. They might have a pounding headache, dizziness, lethargy. Temporary blindness, that's definitely a possibility. It's not one of the more common ones. I haven't seen it. These are the ones we really look out for, but it's the brain. Yeah, it could definitely happen. Oh, it happened to you. Oh, then it definitely happens, right? I'm not sure how common it is. So our treatment here, we're going to basically protect the C-spine. Because they got hit really hard in the head, we don't want to mess around. Maybe they have some neck pain that they're not feeling because of how they hit their head. So we'll probably put them in a C-collar. But really, people with concussions, they're not really likely to die. We're going to transport them if they want to, and they're going to need to be diagnosed. Their recovery is going to take a while. It really depends. Signs of CTE. This is just more so for your knowledge. It really presents with early onset of dementia. They can have severe impulse control. Some of the people we're talking about, some of these NFL players who are relatively normal people, have gotten criminal charges such as murder based off of their impulse control and their brain degradation from CTE. Okay, it can really, really affect people's ability to mentate. So just keep that in mind. Protect your brain, protect your patient's brains. When it comes down to traumatic brain injuries, these are what we consider to be worse than a concussion. A concussion is like a brain bruise, where traumatic TBIs, traumatic brain injuries, are really damage to the brain. And these can present with the similar symptoms, but they can also be a lot worse. People can present completely unresponsive. They can be having bleeding inside their brain, which is increasing intracranial pressure. They can also have amnesia, what we call fishbowl amnesia, where it's not like it is in the movies, where they're like, oh, I'm awake now, and I guess you're my boyfriend or whatever. 50 First Dates and stuff. But it's fishbowl. So an example is I went to a call where a guy got hit by a bus, essentially, in the Winooski Circle, and he hit his head really hard. So he's conscious, and I'm talking to him, and when I first get on scene, he goes, hey, what happened? And I said, man, you got hit by a bus. And he goes, oh, geez. I'm like, yeah, don't worry, I'm here to take care of you, right? I get his name, I talk to him a good amount in those 5 minutes, and then he goes, hey, you, what's your name? What happened to me? And I said, "Sir, you got hit by a bus." And he goes, "Again?" And I was like, no, same bus. And he's like, "Oh, all right." And then we keep transporting him, and he goes, "Hey, you, what's your name? What happened to me?" And I said, "Dude, you got hit by a bus." And he goes, "Again?" And I was like, "No, dude, same bus," right? But he just kept looping back, right? That is a type of amnesia that you can get from this, right? They could also just forget other things. In general, if anybody has a severe head injury, we have to assume that their spine is compromised too. We want to lay them flat, and we want to put a C collar on them, okay? Definitely have ALS coming, and we're going to want to do some assessments of their eyes too. Pupils can really help tell us if somebody has a brain injury. Sometimes if somebody has a brain injury, one pupil is going to be really big and one's going to be really small. One might have a deformed, so it looks like it's a teardrop, like that black circle in the middle of their eyes is now an oval, right? Those things can happen. That tells you they got hit really hard in the head. And bleeding can happen too, right? If somebody gets struck really hard and a vessel breaks, essentially they're going to be experiencing like a traumatic stroke. Just like how somebody can have a stroke from bleeding in their brain, it's essentially going to be the same thing but due to trauma. Altered mental status, paralysis, unresponsiveness. Okay, here are different types of musculoskeletal injuries. Fracture is a broken bone. So this can be anywhere from a tiny little hair fracture, a little chip that comes off, or a complete snap of a bone. A dislocation is when there is a joint, so like an elbow, a shoulder, a hip, a knee, or an ankle, that slides out of its socket. Okay? A joint is like a thing that snaps together, and so then it gives us some motion. Okay? If it slides out, it's painful, and it can tear at ligaments. Now, I hate when medicine does this, and they make two similar words, which respond to two similar things. So I'm going to try to get this right. A sprain, without looking at my slides, is... No, I can't do it. Tearing of ligaments. Okay, a sprain is when the ligaments are stretched or torn, where a strain is a tearing of a muscle. So if I was to rip or tear my bicep, that would be a strain. Versus if I ripped or torn something in my elbow, the ligaments connecting it, that would be a sprain. So, good news though, when it comes to musculoskeletal injuries like this, we do have ways of making a patient feel better and, essentially reducing the amount of injury. Oh, sorry, I just saw your question, Hannah. Why do pupils change? That's a great question for a lot of different reasons. Have you guys heard the saying, eyes are the window to the soul, right? Very romantic. It's not wrong. I would just change it a little bit, that eyes are the windows to your neurology. Your eyes and your pupils are so interconnected with your brain that we can really tell a lot based off of pupil response. So when it gets bright out, right? If I was to look right into this light, my pupils are going to change size to get smaller because there's too much light to not overwhelm it. If I'm in the dark, they're going to open up. So I don't know exactly why they change, but it's because they're so interconnected to the neurology that if something changes in the brain, it's going to reflect in the pupils. Even drugs, right? Opiates, they make them super small, super pinpoint. Hallucinogens or stimulants will make them really wide. And there is a potential, yes, to tell which side the injury is on, because if there's a stroke on the left side of the brain, somebody's right side will be affected, and if there's a stroke on the right, their left. So we don't have enough technology to verify that, yes, it's a right-sided or left-sided injury based off of what pupil is changed, but it can give us some idea. It's typically the one that is abnormal, right? So one that would be super small, whereas one is normal, I would assess it to be on this side. But don't worry about that particularly. Focus on their C-spine. So, signs and symptoms of a fracture. Big ones first, deformities, right? That is a broken wrist. You do not need to know medicine to say that it's not right. Pain, right? He would be in a lot of pain. You can probably say, yeah, that is going to be tender. But let's say that it's not so obvious, right? My arm is just kind of fractured. It would hurt a lot if somebody just barely touched it. guarding is when I would be subconsciously protecting it from you, even though you're not touching it, right? So if you went over, if you saw me doing this, and you came over and you just reached out to like assess me in my arm and I go like that, that's a pretty good indication that my arm is in a lot of pain. Swelling is another big one. That's the body's built-in cast, right? It just swells up so that the skin doesn't move around and the bones stay right there. Bruising is a pretty big one, likely just because of trauma, right? Blood is pooling under the skin a little bit. Visible bones, obviously, right? If you see a bone sticking out, that is a broken bone. And then crepitus, this is a fun word. It means the sound of which when two broken bones rub together. So if you're assessing somebody's arm and it's like really broken and you pick it up and you hear like this crunching, grinding, essentially picture like when you take spaghetti, right? And if you were to break it and then you just like rub the ends together, make like a creaking, crunching sound, that's crepitus. Okay? So if you hear that, pretty good indication that they have a broken bone or broken bones. So a deformity or a dislocation, sorry, this is when a bone slips out. A joint slips out of its socket. There is a potential loss of function. Partial, there's going to be a lot of pain, and depending on the severity of it, they could be tearing the ligaments that keep it there, or they could just be pulling them. So it's actually a pretty common thing. Some people just have easily dislocatable shoulders, and sometimes they can just pop them right back in. But other times, if it's torn out, right, it can be a lot of damage around there. What we'll do in this situation is splint it, and we're going to talk about splinting soon, and then we're going to practice it on Saturday. A pneumothorax. Okay, this is for your knowledge, right? We're not going to be able to treat this. What we would do is ventilate them with our pocket mask. But during trauma, this is one of our big concerns, is that there is a buildup of air in our chest cavity that is going to start compressing one of our lungs. Essentially, this can happen from like a injury to the lung, or a stab wound that opens like a hole from the outside world into the abdomen, or to the thorax, I should say. So when somebody breathes in, right, the diaphragm moves down, and if there's a hole to the outside world, it's going to draw air in through that hole like a second mouth. But that air is not going to be able to leave, and it's just going to build up pressure in the chest until one of those lungs is very, very small or completely compressed. So if we see somebody having difficulty breathing, they have like a hole in their chest, we want to cover that with a dressing called an occlusive dressing. Essentially, it's just a piece of plastic. So we create a new layer so that they're not increasing the pressure. What these people need is something called a rapid decompression, something a paramedic can only do, where they essentially insert a needle into the chest and it lets out the buildup of air. It's actually really cool. How we tell, essentially, is if we see one side of the chest expanding when somebody breathes, but we don't see the other side going. That's a really good indication. Basically, also if they're having a really hard time breathing. Eye injuries. We want to check their pupils to get an idea of their neurology. If there is just something like dirt or little tiny particulates in the eye, we're going to flush it out with sterile water, pour it over that as much as we can. I'm sure if you've seen like eye wash stations at your school in the lab, or someplace if you work at a lab. Now, the main consideration here, if we're talking about something impaled in the eye, we're going to do a treatment that seems a little weird. We are never going to remove anything that is still embedded into somebody, unless it is blocking their airway. Any other place, leave it in, even the eye. Reason being is, if I've got a knife in my arm, that knife is also providing pressure against the arteries and the veins that it is cut. If I was to remove the knife, now blood can get everywhere, right? But if we leave the knife in, it is applying direct pressure to those ruptured vessels. So we would immobilize it, we'd make sure it stays nice and still right there, and we'd wrap around that. Same thing with the eye. If there's an impaled object in the eye, we're going to try to immobilize it. So something like this, you know those little tiny Dixie cups that you see like at offices where they like buy the water cooler, those tiny little cups? that would be perfect. Cut a little hole in the bottom, put it right over so the end of the nail is sticking out, and then tape that there. Now, the weird part is that once we've stabilized that impaled object, we are also going to cover the other eye, essentially making them blind. But there is a reason. It's because our eyes are symmetrical. If there is one eye that's damaged, and we've immobilized it, but this other eye can look around, this eye is moving too. And it's going to be pulling and pushing against the thing that is impaled in. So we cover both eyes so the patient doesn't have to look around and they won't be moving that eye. Okay? But if we do that, we're going to want to be extra verbal and talk them through everything that we're doing, so we don't freak them out, right? Because now essentially they've just been injured and they're now blind for the transport, right? Okay. So now, how would we actually assess how severe a fracture is? What makes a broken bone more dangerous or more severe than another is the effect it has on the circulation and the neurology. It is possible to lose function or lose an arm after a severe injury. Okay, so how we're going to assess an injury like this is by doing these things over here. We're going to assess the pulse, the circulation, sensation, motor function, and temperature. So let's say I broke my forearm, right? What we want to assess is there a pulse below that fracture? So I fractured it right here. Can I feel a pulse on the wrist? If I can't, that means circulation has been cut off by that injury. If I can, that means it hasn't. Circulation that's been cut off by an injury makes it more severe than one that isn't. I can also check cap refill. So capillary refill is if you look at like the nail beds, they're usually like a pinkish color. If you squeeze it nice and tight, it'll go white, and then you let go, and it should return to a pink. So if you look down at your own nail beds, just go ahead and do it. Give it a nice squeeze. You'll see it go white and then fill back to pink. That's capillary refill. We want that to be less than 2 seconds. So if it's diminished, if it's slow, like you pinch it and it stays white for a while and then it goes back to pink really slowly, that means circulation has slowed down. Likely there's like kind of a blockage. After that, right, can you feel me touching you? If they say no, that's bad. If they say yes, that's good. Their neurology is still working. Their nerves are still connected down there. Next is, okay, you can feel me. Can you move your fingers? Sometimes they can, but it hurts and it's really slow. Other times it's just nice and normal. And then finally, temperature, right? What is the temperature of their skin? So this is important because we need to assess this on the broken extremity before we splint it and after. Okay? So that we know, did we splint it right? If all of these things are present and then we splint them and they're gone, they're no longer able to feel, there's no pulse in their extremity, they can't move it, that means we probably messed up. Or their injury has just gotten a lot worse, right? So we assess it before, we want it to stay the same afterwards. So it's very important that you check this before you splint something and then again after. When it comes to splinting, right, if there is an open wound, bandage it. So if somebody broke their arm, the bone went through but then went back in, we're going to still splint it after we've controlled bleeding. We need to choose the appropriate splint for the appropriate injury. We've got a couple different kinds. We're going to practice with one on Saturday. You can apply ice packs. That will help. Transport them in their position of comfort. And then always tell the hospital essentially what wounds the patient has. Never cover a tourniquet with a bandage because it can be hidden, and those are really important. Here are some splints. These right down here below me, these are my favorite. These are really expensive though, so we unfortunately can't practice with these. And these kind of take away the fun of splinting. They're just so easy to use. It takes away the fun of creating your own. These are called vacuum splints. They're essentially just like bean bags that are flat. You wrap them around the injured extremity, and then you take a pump and you pump out the air, and it confines and constricts and contracts and becomes a cast. So I love these. These work really well. What we're going to practice with is that orange thing right there called a SAM splint. So it's essentially foam that covers aluminum, and we get to change the shape to fit the person's arm to immobilize it. Other splints you might see are things like backboards. We used to use these a lot. We don't use these as much anymore. I showed you a traction splint, and then these things too, just like arm boards, can be used for like SAM splints. So we're going to practice splinting just like this on Saturday. You could also create your own, right? If you have cloth and something that's rigid, as long as you follow the rules of splinting, which I'll tell you in a second, you'll make a good splint. So here are the steps. They have to go in order. The first thing we're going to do is maintain manual stabilization. We are going to stabilize their injured extremity. So if my arm is broken and it's flopping around, right, the first thing we're going to do is have somebody come over and essentially splint it with their hands. Keep it nice and still. The patient can do that themselves if they're able to. Hey, keep your arm nice and tight. Don't move it. Hold it nice and tight right there, okay? After that, you'll go over to the arm or the injured extremity, and then you're going to do those PCSMTs. You're going to check that pulse, see if they can feel you. Can they wiggle it? How does it feel? Then, now we can start splinting, but we need to keep this in mind. If it's a bone that is injured, so if it is a forearm, a humerus, a femur, or your lower leg, right, your radius and your tibia and fibia. If it is a bone, you need to immobilize the joint above and below. Okay? So, if it's my humerus, we need to immobilize my elbow and my shoulder. Because if any of those two things move, my humerus is going to be affected. So that means we need to make sure the elbow doesn't bend. We also need to make sure the shoulder doesn't move. So we're going to use a SAM splint, like a splint on the elbow, but we're also going to make a sling for the arm. Right? If it was just my forearm, we need to immobilize my wrist and my elbow. We might be able to do that with a splint. But because the shoulder moves in a bunch of different directions, we need to use a sling and a swath along with a splint. So then reverse that. If the joint is injured, we need to immobilize the bone below and above. All right? That's the standard rule of splinting. Bone, joint above and below need to be immobilized. Joint, bone above and below need to be immobilized. After we immobilize it, we have to check those PCSMTs again. Because if anything changed, we want to know, right? If anything has gone away, we're going to want to remove our splint, check it again, and then reapply it, right? If things have changed, we remove the splint, and now they're back, that means it was our fault. We applied the splint too tight, or we applied it in a way that messed with the circulation. But if we take it off and it's still absent, that means the injury has just gotten worse. We're going to re-splint it and get going. Okay? Takeaways. PCSMTs, before and after. Joint, bone above and below. Bone, joint above and below. All right? We're going to practice that on Saturday. Here's what a sling and a swath looks like. You can't use a sling without a swath. You shouldn't really. And essentially, the sling supports the elbow up, right? It keeps it lifted from the shoulder up, whereas the swath keeps it against the body. So with a sling, right, if it's just holding my arm up, I would be able to move my shoulder like this. But with a swath wrapped around me, I would not be able to. So the sling keeps it up, the swath keeps it in. Anytime you're tying one of these things, always use a bow. Okay, pros use bows. If it's a knot and we have to really quickly undo it, we're going to be scrambling like this, like, oh, why did I get so good at tying knots? But if it's a bow, all you got to do is that. Tie things with bows. Okay, we talked a little bit about shock on the first day. I yelled about Grey's Anatomy. We are going to talk a little bit more, but in general, it's the same thing, right? Blood is not circulating to where it needs to go. It's called hypoperfusion, and it's something wrong. It can happen medically or traumatically. We're talking about trauma tonight, so that's the main reason. So, here are the causes of shock, boiled down. It can either be a problem with the heart. It can be a problem with the fluid, or it can be a problem with the pipes. It's either a pump problem, a blood problem, or a vessel problem. When we're talking about trauma, usually we're going to be talking about volume problem, right? Somebody has bled a lot. That's what we call hypovolemic, right? Low blood volume. Causes to like a pump failure, right? A heart attack, making it so the heart can't circulate enough blood. And then poor vessel function could be like an infection, right? Somebody has body-wide sepsis, so they have a major infection that's causing them to have shock. Here is a chart that kind of shows different emergencies based off of the different types of shock. I don't really want you to worry about memorizing any of this. Just recognize what can cause shock, right? We think about it a lot from just bleeding, but hypovolemic, right? Hemorrhagic is only one of these things. That means blood loss. It could also be non-hemorrhagic hypovolemic. Somebody's super dehydrated, or they've lost a lot of their interstitial fluid from burns. It could be cardiogenic from a heart attack, from CHF. It could be oxygen, right? It could be so many different things. Essentially, shock is a overarching condition that we're always going to treat the same, but we just need to recognize it. And that's the tough part. Because compensated shock, somebody who's compensating, they might have some of these things, but they could also just seem very normal. Because that's the nature of compensating. The body is making sure it keeps itself as normal as possible. However, people who are shocky, people who are in compensated shock will usually know that something is wrong. They will feel it. They will be anxious, restless, they might be agitated, they might be like upset. There is also this really interesting assessment tool called a feeling of impending doom, where if an injured patient, somebody who is really sick or injured, looks at you and says, "Hey, I feel like something is wrong. I feel like I'm going to die." Believe them. That is actually a medical term, and people who tend to say that are tending to be correct. Okay, there's a big difference between somebody like, "Oh my gosh, I'm gonna die." Like, "Oh, but this is so funny," right? I'm not gonna take them for their word, but somebody who just got hit by a car and it looks at me and goes, "Something's wrong, I'm gonna die." Right? I'm gonna say, "Ooh, hey, let's go to the hospital really fast." Right? I'm gonna say, "I'm gonna do everything I can." I'm not gonna say, "Yeah." Right? I'm gonna say, "Hey, I'm gonna do everything I can for you. You're with me, let's get going." Right? But take them by their word. They can be really altered. They're going to have a weak pulse, and it might be feeling a little bit faster. They can have clammy and cold skin, and this is a big, big sign of hypoperfusion. Pale and sweaty skin. Somebody who is pale, cold, and sweating. After an injury or an illness, good sign of shock. Okay? The rest, they're having trouble breathing potentially, shortness of breath, might feel nauseous and vomit. They might have slow cap refill, and they also might be really thirsty. Okay? In general, the best way to know or to suspect if somebody is going to be in shock is look at how they got injured. If you see a severe mechanism of injury, but a patient who seems okay, treat them for shock because they are likely compensating. If we wait to begin treating them until we see signs of lowering blood pressure, getting really lethargic, seeing them get really sick, it's too late. Their body is already decompensating. We don't want that to happen. We want to support them. We keep them warm. we lay them flat, and we give them oxygen if we have it, right? Call help so they can get oxygen. If they aren't able to compensate, they're going to enter decompensated shock, where we're actually going to start to see really tangible signs. Their blood pressure will be falling very quickly. 120 over 80, 5 minutes later, 110 over 70, 5 minutes later, 90 over 60, right? It's going to start dropping. They're going to start to breathe a lot worse. Their skin is going to be very, very pale, maybe gray, even cyanotic. Their pulse is going to be really, really weak, and their eyes might not respond. Their eyes might be dilated. This is too late, essentially. We don't want them to get here. They can still survive this, but it's getting really bad because the next stage of shock, aptly named, irreversible shock. No matter what we do here, we can't save them. So, our goal, keep them here, keep them compensating, support their systems so that we delay decompensation and delay irreversible. Treat them for shock as soon as you get a gut feeling that that injury or that the way they got injured, the situation, nobody walks away from that without injuries. I'm going to treat you for shock. Good news is, if you get them to the hospital and for some reason they aren't injured, it's just a miracle, right? No one's going to fault you for treating them for shock. It's not wrong. You just supported them on the way. All right? So, control external bleeding first. If we just let somebody bleed, they're going to die. This is considered a life threat, right? So if we show up and we see somebody bleeding, before we do their ABCs, we're going to stop that bleeding. Because if we check their airway, we check their breathing, all the time letting them bleed, we're letting them get closer to death, right? So just stop that bleeding and then move on to your assessment. Main things here, keep them flat, keep them warm, get them oxygen if you have it, get them to the hospital ASAP. And then PFA down there, that's psychological first aid. So being there to talk to that person, keeping them calm, explaining what's happening, that is a huge part of being an EMT. Especially for like a VEFR, where you have limited skills that you can actually like physically do on somebody. This is where you are most needed. Higher level providers, they love to do it, but if they have to focus on their high level skills and they have you there to talk to somebody the entire time, that is invaluable. All right, having somebody there to keep the patient calm, be a relatable face, build a rapport, you can't do anything better. All right, so what does the hospital want to know about trauma? Essentially, bad stuff. That's not very helpful, right? But anytime somebody's unresponsive after trauma, they have a really low blood pressure, they're not breathing well enough, there was a field amputation or an accidental amputation, right? Something removed somebody's arm, or there's a penetrating injury to the chest, neck, or abdomen. All of those things would prompt the hospital to call in their specialized trauma people. So if we're picking somebody up like this, you want to call the hospital as soon as possible, right? Let them know as soon as you're on your way with that patient so they have as much time as possible to assemble the team of specialists. This would be considered a trauma alert. They would alert people at the hospital to come help. Backboards. So we used to use these a lot. We used to put anybody who had head, neck, or back pain at any level after trauma completely like Barbie down here. We used to immobilize them 100%. To the point where it was so annoying. There was this guy, probably like 80 years old. He literally just like slipped down to a knee in the parking lot one time, called us because he's having some neck and shoulder pain after. And what we had to do, because he was standing up, was we had to put a backboard behind him and then do a standing takedown where we essentially keep him flat and lay him flat down. It's really uncomfortable. And then completely immobilize him, head blocks and all, transport him, unable to move, to the hospital for him to get an x-ray and say, yeah, I pulled a muscle. It was really annoying. And through studies, we found out that people didn't get better. In fact, backboards made most spine injuries worse. and patients hated us. So we don't really use backboards anymore. We just use C-collars. Here is me being secured to a short board in EMT class. It's just funny because my friend put it on way too tight. So don't do that to your patients. All right, but what we're going to do is we're going to use a neck collar, a C collar, instead of doing this. All right, we used to have to do this all the time for everybody. Now, we just use these two things. All right, if somebody has head, neck, or back pain after trauma, we're going to apply a C collar, and they're going to move themselves to the stretcher if possible, because they know what's hurting them. If we protect their C-spine, we let them move themselves in the least amount of pain possible. We lay them down flat on our stretcher like this, no pillow, no nothing, completely flat, and we transport them comfortably. Okay? Now, here is the assessment which we have to do in order to know if they need or don't need a C-collar. So essentially, we're going to ask this person all of these questions, and if any of them are yes, they fail and they need a C-collar. But if we make it all the way through, they don't need one. So we're going to practice this a little bit on Saturday, but I'm just going to demonstrate it for you right now on myself. I'm not super worried about you memorizing this before Saturday, but this is in your protocol book. This is what we need to do. So I'd take a look at this, just kind of get familiar with it, right? So first things first, do they have an injury, or was there a mechanism of injury that could potentially cause head, neck, or back pain? That's why we're doing this. If they're under 18, they get a C-collar. Okay, it's just one of those things we don't know. We don't want to risk it. If they're a child, they don't get to go through the assessment. They get a C-collar. We treat them carefully. If they're an adult, are they anxious? Are they cooperative? Are they able to understand? Somebody who's freaking out, somebody who's running around, right? They fail. They need a C-collar. Somebody who's able to talk to you and say, yeah, I know I'm in a car crash. I'll keep my head nice and still, right? We can move on from there. Are they altered, or is there evidence of intoxication? If they have had anything to drink, really, any drugs of any kind, we have to put a C-collar on them because the effects of those drugs could be suppressing a pain of an injury that they have. Next one is distracting injuries to themselves or others. So if I have a really bad broken arm, I'm getting a C-collar because this pain might be dulling or overwhelming the pain that I'm feeling in my spine. The other thing in there is if I'm driving a car and I get in a car crash, and my girlfriend is in the seat next to me and she's really, really hurt. She has a bad broken leg. I am now distracted from her injury. So I would need a C-collar. Okay? Oh boy. Anyone remember? Distracting injuries. Distracting injuries. Cool. All right, let's do this fast so it doesn't crash on us again. So if somebody's injured next to me, right? Say I crashed my car and my girlfriend's in the side and she has a broken leg. I'm no longer concerned with my injuries. I'm distracted by her injuries. I get a C-collar. Okay? After that, it's anything abnormal with their neurological function. Any tingling or numbness in their hands or their feet. If any of that is there, C-collar. Now, those are all questions. We haven't really touched them yet. Next thing is, do they have any pain when I palpate their neck, their head, or their back? If at any point there's pain, they get a C-collar. And if there's no pain on palpation, what I'm going to do next is have them move their head forward and backwards. Okay? If there's no pain with that, I'm going to have them go side to side. If there's no pain in that and I've asked everything, we can say, all right, you don't need a C-collar. But if at any point they fail, they get a C-collar, they get laid down flat on our stretcher and brought to the hospital. We will not remove a C-collar until the doctor removes it for us. All right, again, we're going to practice applying C-collars so you get a good fit for it. And then this is just something we want to have in the back of our minds. Think about why, right? We're working our way down to assessing their neurological function. Any sign that there might be a head, neck, or back injury, they get a C-collar. Protect that C-spine. Only if you're being really, really rough. Okay, when we're palpating something, we are gently walking our fingers down. We're not squeezing, we're not pushing, we're not pulling. Okay, it is just a tender touch to see if it hurts, to see if there's anything out of the way. All right, so be careful. Yeah, be careful when you're palpating it. Don't be like, does that hurt? Right, be kind. All right, so applying one, you want to provide stabilization. So we're actually going to have somebody hold their head like this, hold C-spine. We're going to wrap the chin support around. We're going to size it, and then we're going to snugly fit it. Make sure it's tight enough where they're not going to be able to like slip out of it, but also make sure it's loose enough where they're not going to be like choked and be able to speak. All right. Any questions? Well, you did it. You made it this far. You listened to me talk for 3 hours for 3 nights in a row. Even I was getting annoyed with that. Okay, so good job. Thank you for being here. Last housekeeping things before we go. If you want your VEFR certification, you need to attend the skills lab on Saturday. If you do not come on Saturday, it's kaput. You can't make it up. It's done. I'm sorry. All right? Hands-on training is the most important part. I can't just do multiple Saturdays for people who can't make it. Come on Saturday. It's going to be a lot of fun. Meet me in person. Meet my friends. Learn hands-on skills. Reminder, your online learnings are due by Monday. So the 26th, they need to be in, or else you will not do it. Send the certifications to me via email. You should have been able to download them like a picture. That's how you get them from the website. Send them to me on an email, and I'll put them in your file. Also, if you missed any of the live lectures, remember you need to watch the lectures and answer the exit tickets by Monday. If there aren't submitted exit tickets for those lectures that you missed, your chance is kaput. You have not completed the course. Okay? If you have questions, you need to confirm with me, just email me, right? If there's something coming up, reach out. Other than that, my last thing is thank you. Because every time I teach one of these classes, I always am just really excited and really impressed with you guys. You are the ones who decided you wanted this opportunity. You're the ones who decided you wanted to spend the weeknights and a Saturday of your life close to a winter break or whatever, learning how to help people. All right. It's a tough job, and I hope that I've been honest with you about that. I hope that you're still excited, because in medicine, there are always good and there's always bad. But I'm always very impressed to see people like you. So thank you for being here. Thanks for being with me for these lectures. And I will see you on Saturday. If you have any questions or concerns, send me an email. I'll be around all week. Again, afterwards, too, I will be a resource for you. So it was great to have you guys here online, and I'm looking forward to seeing you on Saturday.